مفتوح حضرتك؟
Thank you. I just want to make one or two comments. First of all, the comment has already been made. We always try anti-gravity and with subintimal angioplasty, it's almost always possible to tackle these lesions because you use a catheter like the one you showed, you engage it in the opposite direction to the collateral and you can always find a dissection. Almost. The other comment is, as you saw in my lecture, we hardly ever use stents because we don't treat appearances. An appearance of a dissection, in our opinion, is not a reason to stent. The flow is good, we just leave it. And one very important reason why one shouldn't stent, if this patient comes back 6 months later, 1 year later, occluded, it's the end of the story. We need surgery or something.
Yes.
Whereas if he came back to us having had a subintimal procedure with a reocclusion, we can re-intervene and we do it many times, 3, 4, 5 times. So I think that's an important point. You've got to remember that when you stent, you are ruining any future prospects of a re-intervention.
Yes, but we are somehow worried to treat the total occlusion with no stenting. How much the reocclusion of the stent of the vessel after the opening without stenting or something, or drug-coating balloon. We don't have drug-coating balloon actually at that time.
We talk about vacancies of
Yes. 50%?
At least 70% at 1 year.
Yes.
But as I say, with reocclusion, you always have the option to open it up.
Yes.
Well, for the last section.
Thank you very much.
Thank you, Mr. Chairman. I'm sitting with the Vice President in chance. The case is very impressive and I enjoyed it.
Thank you.
There are real fears and real concerns pointed out to by William. Now, what has been done is definitely on the short term, is very good.
Yes.
But there are real concerns on the long term because the natural history, this is a typical Berger's patient from the angiographic appearance. These are the real corkscrew, and it's not really the so-called good atherosclerotic candidate.
Yes.
Which means that the process of pan-arteritis is ongoing because those patients do not really ever stop smoking. They keep smoking.
Yes, of course.
So
And that is the case.
So a word of caution probably now that stents are there, an extended period of dual antibiotic is highly recommended.
Yes, of course.
Plavix plus aspirin.
Yes.
Beyond the usual agreed protocol of like 6 months or even 9 months.
And anti-lipid also.
Yes.
Of course.
Number two, probably I share just one point. A redo balloon angioplasty is far better, more easily managed than an instant response.
Totally agree. Agree.
After all,
I totally agree. Yeah. Yeah. Thank you.
Next session with Felix Conclusion, and we can conclude the session.
Yes.
لا لا خلينا نشوف. لا ده مش اتش دي. لا خلاص مش شغال حاليا بي جي. لا 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 خليني اسف حضرتك.
Now we are going into this very interesting session, 6. Session. Do you have Dr. Sharif Rashid? Ready? Yes. My introduction University. Actually, this exemplifies the very fruitful kind of cooperation between the vascular surgeon and the pathologist, as there is such a great zone shared by both subspecialties, the urology and vascular surgery. And this topic is highly fitting. I hope you enjoy it.
Thank you very much. Thank you very much, professors and doctors, to allow me this opportunity to talk a bit with you about the considerations we see to build a hybrid room for vascular surgery. Let us first talk, is it a necessity or not? What we can see now in the market is that endovascular treatment is getting more and more complex, while surgical treatment is getting less invasive. So we are trying to meet somewhere in between. If we think about the hybrid OR, we are thinking about a typical OR environment with all the sterility, surgery, clean air, anesthesia, surgical lights. At the same time, we are talking about intervention, about endovascular, about fixed X-ray system. So both of them constitute the hybrid OR. But this is a very shallow, simple way of thinking, because this will lead us to a situation where we are just gathering all the equipment next to each other, and as we can see here, we cannot find the patient. So let us first ask ourselves, why do we need a hybrid room? Do we have the rationale for a hybrid room or not? There are some 21st century procedures that are requiring this to happen. The most prominent two procedures that require hybrid rooms are in the cardiology field, the TAVI, and in the endovascular field, the EVAR and TIVAR. These are the most important procedures for which hybrid was invented. Based on the new procedures, we can anticipate that in very near future, we will be having some kind of cross-speciality, some vascular interventionist or minimally invasive phlebotomist, more or less, who is somewhere between a vascular surgeon, but with the capabilities of an interventional radiologist. And the same we can see in cardiology between cardiac surgery and interventional cardiologist. So, if we have a short look on the TAVI, this is the typical way of doing TAVI, but with hybrid OR, we can use fixed systems as well in the same environment to draw exactly how the valve looks like and the plan we should implant it at, including some landmarks for the coronary osseous. This is very important. Based on that, we are talking now about abdominal aortic aneurysm cases. This is the typical original way, 1950s, and then now in a hybrid OR, we can do it in an endovascular manner, as we have just seen in the past two presentations. As we can see from a market perspective, open surgeries are getting less and less, while endovascular surgery is getting more and more. And we can see the prevalence now of EVAR and TIVAR procedures. It is growing over years. And here in the endovascular today, in the March 2013, they were mentioning about which procedure are getting more and which procedure are getting less. Of course, this is in Europe, but I believe we are not very different from that trend. We can feel that trend as well in. Based on that, we can see that there is some clinical drivers, some shifted focus of specialty, and some financial drivers. We can see that we are opting for less mortality we are opting for less stay in the hospital, because now most of the new insurance companies are measuring the treatment per result, not per stay as before. So they pay per the result of the treatment. This is the market of hybrid ORs. This is from our industry as imaging companies. We can see that in the year 2001 and 2002, we are talking 1 or 2 hybrid ORs to be installed per year, while now we are talking 400, almost 300 systems to be installed per year. This is the total market, including all vendors. Then we shift into the design considerations. What should we put in mind while designing a hybrid room? We should look to do more with less, because now hospitals do not have open budgets as before. So we need to think how to make the best use of the room we're going to build. We need to see whether this budget will be considerably having a return on investment or not. And how can I get and maintain the technology to deliver the best results, because this is what we need, best clinical care, and optimizing the operations of the room. And then we need to put in mind the staff training. Of course, when we talk about optimizing, we might see in some tertiary care hospitals that the hybrid room, for example, is a shared service, but then it will need a special design between different departments, where, for example, vascular surgery will have their own ORs, but 1 day per week or 2 days per week, they use the hybrid OR for cases that require hybrid OR. At the same time, cardiac surgery, they will have their own ORs and sharing with vascular another couple of days. Things like this. These are smart ideas to get the best use of the investment we're going to do. Then the design of the room. It should be mainly designed around the clinical workflow. Clinical workflow is the most important thing, because we have to put in mind all the OR environment parameters that we had in mind while having the cath lab environment at the same time. This is, in our opinion, how a hybrid OR should look like. Clean floor to ensure sterility, central clear area to install laminar jet flow, and then the docking table to put a surgical table which has both the benefits of surgery and endoscopy. Here we can see the lights, we can see the monitors everywhere. It should be in multiple places, not only in a single place as in a cath lab. Laminar jet flow should be installed in the middle of the ceiling, and this is the dockable surgical table. Of course, we will choose whether it's a surgery table or an angio table, depending on the percentage of cases and the type of the procedures we're going to do. And a fixed X-ray system. I believe this is the definition of hybrid everywhere. Then we have to bear in mind, for example, we as Philips, we have something called Flex Move, which is special extra sealing to accommodate the laminar jet flow for ceiling suspended systems. And we have the ambient experience to ensure the working atmosphere is very convenient for the staff and even for the patient before patient's anesthesia. And Mackay Magnus table, this is the only table integrated for hybrid up till now. Other companies, of course, are catching up. And robotics integration. For example, if we're going to use Magellan robotic system for vascular surgery, it has to be fully integrated into the system. This is the Mackay Magnus table. It has 2 tabletops, interchangeable, the surgical one and the fiber optic one, carbon fiber. Or alternatively, we can use the table from the angio company, from the angio supplier, but in that case, we need to add some special features on that table, like, for example, lateral tilting for cardiac surgery and longitudinal tilting for vascular surgery. So these are things that we have to bear in mind. Then this will be the total room. You will be having an anesthesia equipment, you will be having, for example, the large display, laminar airflow is there, multiple monitors everywhere, OR lamps, and the setup of the room will be different from each procedure to another. The most important is workflow, how the patient will be done, where will be each of the staff standing to allow the flexibility for the staff to do what they should do. Anesthesia people where they are, perfusionists, things like this. So we are trying to help in identifying the clinical needs and workflow. We also try to translate the needs into the best design, and we help in project management. It starts with the room design, room planning, putting all the stakeholders in mind. It's not one person ever that can decide how the room will be. It should be a teamwork, because every one of those stakeholders has his or her own workflow. So we have to put them all in mind. And we have to ask ourselves plenty of questions before we decide. For which application? How much is the percentage of each application? Is it more surgical and endovascular randomly, or the other way around? So all of this, what are the adjacent equipment? So all of these questions will help us decide exactly what do we need and how are we designing it. Usually in a hybrid suite, we are talking more than 60 meters, which is a very small hybrid. We prefer the hybrid to be very large. And always there is center of attention is the patient on the table. And then there is an anesthesia area, there is a sterile area, and then there is working sterile area as well. These are the stakeholders standing there: anesthesiologist, surgeon, vascular surgeon, okay? And of course, we build the equipment based on that. We put the table, the X-ray system, display. X-ray can be right or left of the system. OR lights, lead shielding, sterile air, pendants, ultrasound if needed, and contrast injector, instrument trays, other equipment. This is in Karlsruhe in Germany. This is an example of this room with all the stakeholders that we talk about now. This is in Karlsruhe, also in Leipzig. This is the laminar airflow solution. It's a special solution on the ceiling because our system is a ceiling suspended system. Generally, the flex move allows that we put laminar airflow without interruption with the sterility of the room, while at the same time, since the system is sealing already, so the floor is already clean. Actually, this is the whole concept about hybrid. We need a clean floor to sterilize around the patient table, and we need a clear ceiling to put the laminar airflow in. A hybrid OR means no equipment on the floor. That's why, from a geometry perspective, we can see that in the market, there are like typical three trends, you know? Either to have a ceiling with a laminar airflow special solution, or to have it floor but mounted away, far away from the table to allow clean area around the table, or to have it floor on wheels, so that to allow as well clean floor. I mean, this is the concept. It should be having clean floor and clear ceiling. Then if you go to the setup, this is, for example, a typical EVAR setup. Each procedure will have a special setup for the lights, for the table, for the X-ray equipment, for everything. So each and every procedure will have a dedicated setup, and not only a setup, but also a dedicated bunch of interventional tools. And the interventional tools are actually the reason why we are going for a hybrid room. Because if we were going to go without interventional tools, mobile CR can do the job fantastically and doesn't need any requirements. I mean, just a high power CR and it works. I mean, the main reason why we have gone for a hybrid room is that, and we are doing all of this installations, is that we need the high capabilities of the fixed system, which are mainly now those interventional tools. This is, for example, doing roadmap using CT angio or MR angio for the same patient done before. Then we do fluoroscopy overlay on the CT angio or MR angio. This is navigation in 3D. We can save plenty of contrast during TVAR. And there was a very famous study done by Hicham Koubeter in Henri Mondor Hospital in Paris. It's called zero contrast road mapping. This was one of the very famous ones, and he was doing road mapping with zero contrast. We can do CT, so the system can do CT during the examination itself, preoperatively, and during the operation itself, without the need for a previous CT for the patient. And this is usually helpful in cases, for example, where we need to check the stent, if we have put an aortic stent, and to check also the endoleaks. We need to check the endoleaks usually using 3D rotational angiography and CT. And you can use the 3D rotational angiography to make an endoscopic view for aneurysms, for example. This is another use for 3D rotational angiography. This is a case of an internal iliac embolization where we have been using the MR and CT data set to be overlaid in the fluoroscopy. Here is a case, for example, for an inferior vena cava filter removal. We were trying to remove an obese inferior vena cava filter, but it was not going very well with the 2D image. But then we can see now with the 3D how it is very easy. It became much, much easier to get it using the 3D tools. This is the value of the 3D tools that we have on hybrid. This is a case of internal carotid artery stenosis, where we are normally using plenty of contrast. We can see here 40 to 45 cc's in aortic arch. But then we can see here an example of the usage of 3D tools to minimize contrast as much as possible. And even here using a thick slab, unsubtracted CT angio will help us with the fluoro overlay to have the best solution. Here is a small video for a common common carotid stenting case where we see very clearly that the movement is very well compensated. So the movement, expiration movement of the patient is very well compensated. Table movement is compensated, and system movement is fully compensated. So here you are seeing clearly without any kind of shift. Then we go to the last point. How can we use the full potential of the room? That's very important. We have invested plenty of money, and we need to make the best usage of this money invested. These are the technologies available in the market. Starting by the 3D rotational angiography, which is building us a volume rendering 3D image for the vessels, peripheral vessels. And we can see, for example, here, endoleak type 1 detection after stent grafting. That's very important to detect it. And we can use the same for aortic arch. We can use the same for pulmonaries and renal arteries. Then we can use the same feature to do what we call virtual stenting. It allows us exactly to make a full simulation of the stent we're going to put to see exactly where it will be looking like and how it will be looking like. We can also see the calcified plate imaging using the endoscopic view, and we can see spine view using the 3D RA. The most important in 3D RA is that it has to be linked to the arm, so that whenever you move it, arm moves and vice versa. This is very important for the clear orientation of the constructed volume. Not only this, in cases of aneurysm, we can make a see-through visualization to enable us to check exactly how the aneurysm looks like from a topography point of view. You can see here that we can make this kind of see-through to check it. Automatic vessel assessment is also there, included in the same feature. So you can make quick 3D distance measurements. For EVAR, we can do the CT, expert CT. This is a typical CT done by an angio system. And we can overlay it, of course, with CT angio or with any modality else. From all sections, you can do it sagittal, coronal section, as you wish. Then we need the live 3D needle guidance, usually to treat an endoleak that happened after an EVAR case. And with the live needle guidance, usually we see the needle protruding live in a 3D manner against a planned pathway. This is the live 3D road mapping, and it's different from the 3D road mapping, because with the 3D road mapping, you see only one picture, but once you start moving the gantry, it will stop and reconstruct. Now you can see you are moving the gantry while it's working fantastically. This is what we call live 3D needle guidance, not 3D needle guidance. Here we can see the same for a carotid stent. It enables us, as much as possible, minimize the procedure time and effort to do more cases, and that's why we call it high return on investment. And then here, this is an MR angiography road mapping. This is the zero contrast we were talking about. The last thing is the perfusion. For peripheral vascular diseases, many times we see that we revascularize the tibial artery, for example, and then the patient comes in a couple of months with need for amputation. Why? Because vascularity of the sole was not sufficient. So here, with the perfusion, we can see exactly the vascularity in relation to time. So it's not only whether the blood goes there or not, but the blood goes there when. This is very important. I would like to thank you very much for your attention and looking for your questions.
Thank you very much for very nice element session. Now we receive a question on the floor. Professor Dr. on the floor.
Thank you very much for a very nice lecture. I will just go to your last slide, the perfusion. I'm really very interested in this technology because this is the first time we get an angiogram and something equivalent to peak systolic velocity, which will tell you the speed. And I've actually asked about it. It seems just it's software integration because recently, I think I know maybe 4 or 5 hospitals they already bought new Philips machines. Does this software only goes to hyperintro, or you can put it to other machine? And I know that there are 2 hospitals in Italy which have started to do this in diabetic foot with fascinating results and fascinating images. Thank you.
Thank you very much, Dr. Omar. Actually, it is available already in Egypt on one system installed already, and as far as I understand, we are starting some kind of a clinical research on that. It is upgradable to the other equipment installed in the past 3 years, so we can upgrade any of the other equipment available into that feature. It's a one-day upgrade. It's not only software, of course, it has a special small hardware with it, but it's a one-day upgrade that can be done. So it's available. It's available. We are ready to do it. Already one system is installed since around 6 months or 8 months, and they are very fascinated with it.
Question from the panel, Professor Dr. Anderson.
The key word for vascular surgeons comfortability is to have nearby at hand a hemodynamic tool. Time and again, we have seen cases where successful vascularization has been made, whether any local organ or hybrid, but just seeing the pictures does not 100% of the times correlate with the income. So, question number 1. If we are talking about a hybrid tool, you have to do it that I understand your presentation. If we are having nice ultra modern mobile CR units with us. Are we not talking about hybrid anymore? Hybrid OR? So
yeah.
this question number one.
Yeah, actually, the word hybrid means that you are integrating two things that should not be together, but you are trying to mix them together. Actually, since long time, ORs have been having CRs, mobile CRs. And currently, there are good mobile CRs, those the new ones with flat detector. But the idea is that none of those CRs up till now has reached a point where the 3D tools are reliable and we can depend on them. While those systems have been long time designed for non-surgical use. And this non-surgical use was starting by cardio 30 years ago, and then it moved into vascular 10, 15 years ago, and then neuro, and then oncology. So the development that those companies have done already in the interventional tools is already high, and all of those features are like approved everywhere. Still, of course, as you mentioned, the hemodynamic parameters are very important. That's why in a hybrid room, typically there should be a hemodynamic recording system, preferable to be in many cases an IVAS system. Maybe also now with the new trends like near infrared, like OCT, like all the new trends coming now. But at the end of the day, what we believe at is that you need an image to work on while having the support of the parameters from the physiologic monitoring and hemodynamic, having the aid from the OCT or NIRS or IVAS or FFR. But at the end of the day, the image you are working on, and you can see your catheter protruding on dynamically, is the image coming from the X-ray system, whether it's Philips or other brand, you know. So this is the image that we are trying to make it have the maximum criteria of data, so that to enable you make the things you do faster and easier. But you will, I mean, it will not make you do something that you cannot do. The whole idea is that with those tools, we are trying to make the case that takes a couple of hours, take half an hour. That's it. So that you can do plenty of cases in a shorter time.
Second, last question.
Yes.
Correct me if I'm wrong. The only two applications that where the beauty of the hybrid OR with the function evidence for the vascular surgeon or the endovascular surgeons is EVARs and carotids. Am I right?
Yes. For vascular, it's EVAR, TVAR, and carotid. These are the main two. Of course, other things that might need very little, minimally invasive things, like peripheral, for example, might be of an added value, but it is not a reason to buy a full room just to do below knee, for example, procedures. Definitely, this is not a reason to buy.
How much it costs to shoot full room?
Yeah, for the room, actually, you, number one, put in mind the system itself. The system usually now in Egypt between companies, depending on the interventional tools we are talking between 6 to 9 million pounds, Egyptian pounds, including sales tax. This is just a rough estimation. But then the preparation of the room costs almost from 1 time to 2 times this amount, depending on surgical capsule, laminar airflow, table. For example, this table, the Makibatas, is an extremely expensive one. So if there is no need for it, we can go to the angio system table instead. Anesthesia, monitoring, suction. I mean, we have plenty of things. Even the special preparations from the angio system will add money. For example, if I need the tilting table, this will add money. If I need double displays, this will add money. If I need surgical lights with integrated camera, this will add money. So there are plenty of things to add money. So usually the basic system is alone as a cath lab or as an interventional imaging system. We are talking 6 to 9, but then you add, let's say, an average of another 10 for the other things, you know, like all the other things you need to do. Of course, that's why I always believe the hybrid room is like a project that It's like someone asking a contractor to build a villa. You have to tell me how many rooms you need, how many floors, what kind of finishing. I mean, plenty of things. It's not like one system that I offer. That's the hybrid, you know. I mean, the word hybrid is a very vague one. So we need to highlight exactly our needs. Based on that, we can assess exactly how much can we spend.
Thank you very much. We can move the session now.
Bismillahirrahmanirrahim. The next session moderator will be Professor Tariq Radwan, and we have on the chairperson Professor Mamdouh Muzayyim, and it's about new technology in PVD. And the first lecture is one of the most eminent vascular surgeons all over, not just Egypt, but now Middle East and North Africa, which is Professor Sam Al-Wadi.
Now we'll start session 7, new technology and and I also should have a party session with session because we have two eminent parties with us. One of them is a vascular surgeon and the other is a cardiologist. We'll start with Dr. Sam Al-Wadi, who's one of our colleagues. We know each other for 65 years now, and he's going to be the head of vascular surgery in Miami, and then is one of the men responsible for the up-to-date achievements in medical service.
In the first, actually, I would like to thank the conference committee to give me this honor to give this presentation today. I would like to thank Professor Dr. Rida Al-Asawi, Professor Dr. Nabil Farag, and Professor Dr. Muhammad Omar Farouk for this kind invitation. Mr. Chairman, I will talk about my experience in the European Society of Vascular Surgery annual meeting, which held in Sweden and the Stockholm last month. It was very impressive, actually, for me, this meeting. I will start with this nice building, actually, this massive castle. It is the City Hall building, اللي هو زي المحافظة كده عندنا. والسيتي هول ده أنا اكتشفت لما عملوا لنا فيه الأوبن سيرموني دينر إن ده المكان اللي بيتوزع فيه جائزة نوبل كل سنة. وإن الحقيقة حاجة أنا لما دخلتها من جوه الحقيقة حاجة مذهلة جدا، ويعني قد إيه الواحد حس بعبق التاريخ في هذا المكان، وإن في ناس كتير جدا عظماء دخلوا هذا المكان، وهم الحقيقة بعد ما الدينر طلعونا في الأوضة الجولدن هول اللي هي القاعة الذهبية اللي بعد ما بيوزعوا جائزة نوبل بيطلعوا الناس كلها يرقصوا فيها. الحقيقة مكان تاريخي جدا، والمكان كله الحقيقة كان عظيم. أنا الحقيقة لما الدكتور محمد عمر كلمني علشان أقدم توك في المؤتمر ده، أنا فكرت إن أنا أحطكم بس معايا في الصورة الناس دي وصلت لحد فين. الناس دي وصلت بعيد قوي عننا الحقيقة. أنا حسيت قد إيه إن إحنا في الإندوفاسكولار وخاصة في الأورتيك إندوفاسكولار في الإيفار والتيفار والحاجات دي إحنا لسه متأخرين قوي الحقيقة يعني. الحقيقة أنا هعمل سبوت لايت سريعة على الحاجات، بس عايزكم تاخدوا بالكم قوي من الأعداد اللي بيعملوها في الفترات اللي بيشتغلوا فيها، وقد إيه فعلا زي ما قال الدكتور أيمن أبو المجد إن قد إيه الناس دي عاملة very good registry في الاسكندنافيان كانتريز اللي هم اللي حوالين بعض، قد إيه عاملين very good communication، قد إيه عاملين very good recording and database لحالاتهم، وبيطلعوا منها a very serious studies. The first talk it was talking about new drug actually اللي هو algolivitine that prevents further dilatation of the abdominal aortic aneurysm through antioxidant and anti-inflammatory effect in rats. الحقيقة الاستادي دي قلبت الدنيا في أوروبا لأن النتائج بتاعتها على الراتس very positive، والدواء ده الحقيقة مشهور جدا في أمريكا وأوروبا. في أمريكا اسمه نيزينا، وفي أوروبا اسمه فيبيديا، والحقيقة very popular كهايبوغلايسيميك دراج. والحقيقة كان الكلام في الاستادي دي إن هم ابتدت فعلا ترايل تو الكلينيكال فيز على الهيومن في هذا الدواء. الحقيقة الدواء ده لو طلع وبقى ابرود فور هيومن لانه يقلل الدايلاتيشن اوف ذا انيوريزم، هيحل لنا مشكله كبيره جدا في العيانين اللي بيجوا بايرلي انيوريزم 5 سم ولا حاجه واولد ايج، ويبقى الواحد بيبقى متردد هل هيعمل لهم حاجه لو جاله بعد 6 شهور ولا سنه بقى 5.5 ولا بقى 6، وهيبقى اولدر وهيبقى مور ريسك فاكتورز. فالحقيقه الموضوع ده واخد اهتمام كبير جدا من العالم في الغرب. The other presentation كانت عن 10 years experience with endovascular repair of thoracoabdominal aortic aneurysm result from 165 consecutive patients، وده اتعمل في ألمانيا. والحقيقة ناخد بالنا ان بقى لهم 10 سنين بيشتغلوا thoracoabdominal، وبعدين عملوا 166 عيان في ال10 سنين ديت، ده في سنتر واحد في مكان واحد. الناس دي بتقول ان الفينستريتد اند برانشد ستنت in high volume center appear safe and effective in the mid term, except for re-intervention rates, and this result compare favorably with published series of open thoracoabdominal aortic repair despite treatment of a high risk of patient. يعني الحقيقه البيبر دي كان عليها ديسكشن كتير جدا جدا، لان هم كانوا بيتكلموا على الفينستريتد والبرانشد ستنت جرافت دي على انها حاجه روتين وبتتعمل كل يوم، لكن هي النقطه كلها الكي وورد الحقيقه في الكلام كله انها هاي فوليوم سنترز، وهو ده ما نفتقده في مصر الحقيقه. كل واحد شغال لوحده، كلنا في جزر منعزله. الحاجات دي يا جماعه بتتعمل بره في اوروبا في سنترز، مش كل واحد في اي حته بيدخل يعمل حاله زي كده، وده اللي بيخلي نتائج. والسنتر ده كلنا بنروح نشتغل فيه، اللي عنده حاله برايفت بيروح السنتر ده يشتغلها، اللي عنده نايب بروميسنج وعايز يطلع يشتغل في الكلام ده بيروح، اللي عنده ريسيرش ورك بيروح السنتر. لذلك السنتر بتبقى نتائجه، عشان كده الناس دي سبقانه. انا من ساعه ما رجعت من انجلترا، انا بقالي 15 سنه راجع من انجلترا واحنا بنتكلم عن الاندوفاسكولار واحنا بنشتغل اندوفاسكولار، لكن احنا لسه بعيد برضو عن الناس دي. ده كلام 10 years experience فينستريتد اند برانشد ستنت. كم واحد فينا عمل فينستريتد جراف؟ كم واحد فينا عمل برانشد جراف؟ لان الناس دي بتشتغل في هاي فوليوم سنتر. لازم نفكر في الكلام ده يا جماعه، لازم نجمع شغلنا في مكان واحد، ويبقى المكان ده هو اللي بيبقى فيه التعليم، يبقى فيه الحالات، ويبقى فيه الاكويبمنت، يبقى فيه الاكسبيرينس، ويبقى كلنا نشتغل في هذا المكان، ونخلي كل مكان متميز بحاجه بتاعته، وكل الحالات يتعمل لها بولينج في المكان ده. وده اللي منجح البلاد دي الحقيقه. يعني المانيا ما فيهاش غير 2 or 3 سنترز اللي بيشتغلوا الكلام ده في كل المانيا. دي الحقيقه برضو حاجه من البيبرز اللي بهرتني جدا، انهم بيتكلموا عن التي فار في البلانت تروماتيك ثوراسيك اورتيك انجري في اللونج تيرم اكسبيرينس فروم 2 تيرشري ريفيرال سنترز. دي بقت النهارده روتين عندهم ان هم يشتغلوا في الحالات دي، وفي البيبر دي مقدم 46 حاله with blunt aortic injury and re-intervention is needed in roughly 1 in 6 patients during the first year, but after that it is very uncommon. the long-term survivor in this patient is excellent, and the initial outcome is highly dependent on the severity of other injury. Another presentation الحقيقة من فرانس كان بيتكلم على minimum 10 years follow-up of endovascular repair of acute traumatic transection of the thoracic aorta. يعني ناس بقى لها 10 سنين بتشتغل على الكومبليت ترانسكشن اورتا وبتعمل له endovascular repair. برضه دي كلها سبيشالايزد سنتر. والناس بتكونكلود in improved operative mortality of TIVAR over open in the last over time without any devices or procedure related complications. يعني وصلوا لحد انهم بيعملوا الكلام ده في transected thoracic aorta بالاندوفاسكولار على مدى 10 سنين، ان هم بقت بأقل بكتير في الديفايس او في البيشنت كومبليكيشن. دي برضو بتتكلم عن الرابتشر اوف ذا تايب بي اورتيك دايسكشن، وان هم برضو كان في نفس السنتر في فرانس، وعاملين عدد كبير جدا في الحالات، عاملين 24 حاله في خلال ال 14 سنه اللي فاتوا في السنتر ده، بس في سنتر واحد. وازاي ان هم قللوا جدا ال 30 days mortality. برضو ده في نفس الموضوع بس كان في اليابان. وتشوف اليابان دي معديه بشكل غير عادي في الاندوفاسكولار. الولد قام اتكلم الحقيقه وصور السنتر بتاعه اللي هم شغالين فيه، وازاي ان هم عاملين عملوا اكزامينيشن ل 234 عيان على مدى 6 سنين في عندهم كده، وعالجوها بالكلام ده. والاند ريزلت this should be sufficiently considered in treatment of type B aortic dissection. ومع ذلك يعني عاملين شغل على 234 عيان، ومع ذلك بيكونكلود but further prospective study is necessary. دي برضو حاجه من البيبرز الحقيقه اللي خدت a lot of discussion، ان end to end inner to inner ولا outer to outer diameter. لان هم الحقيقه لقوا ان لما بيعملوا inner to inner diameter بيقللوا الهاي ريسك رابشر في السكريننج بروجرام بتاع الاورتيك انيوريزم، احسن من outer to outer diameter. والحقيقه ان هم لقوا ان دي بتفرق كتير جدا في الانترفال بتاعه السكريننج، انهم بيخلوها 7 سنين بدل ما هي كل 5 سنين زي ما بيعملوها. برضو اتكلموا في الفينستريتد والبرانشد اندوجرافت على الرينال اوت كام، لان كان في كلام كتير جدا. برضو لو نلاحظ انهم على مدى 8 سنين عاملين 225 حاله was treated with fenestrated and branched EVAR. والحقيقه الكونكلوجن بتاعهم ان الرينال ديسفانكشن كان اقل بكتير، وكانت الرينال موربيديتي قليله جدا في كل هذه الحالات. اجين السباينال كورد اسكيميا، وده كلام برضو كله في الثراكو ابدومينال اورتيك انيوريزم ريبير. والحقيقه ان هم بيكونكلود ان ده ان الجود سيلكشن اوف ذا بيشنت اند جود تكنيك بيقلل جدا السباينال كورد اسكيميا، رغم انها كانت عاليه جدا في الاوبن ريبير قبل كده. ده الحقيقه الاستادي يمكن الوحيده اللي كانت في كل شغل الاورطه كانت على الاوبن. في الثراكو ابدومينال اورتيك ريبليسمنت كانوا بيتكلموا فيها على البيتنسي بتاعه الرينال والفيسرال فيسلز بعد الاوبن ريبير in 131 patients to over 10 years, and in their study of open thoracoabdominal aortic replacement, excellent patency rate for revascularization of renal and visceral vessel were observed during long-term follow-up. and they were able to provide a reference value of long-term vessel patency that can and should be taken into account for judgment of efficacy of endovascular repair في الثراكو-abdominal angle. يعني هم الحقيقه في منافسه، في سنترز بتتنافس في اوروبا دلوقتي، لان ما زال هناك a lot of believers ان الاوبن ريبير احسن في اللونج تيرم ريزلت، خاصه في السايد برانشز من الاندوفاسكولار ريبير. فدي الحقيقه المدرسه دي قدرت برضو من المانيا، وقدروا ان هم يفرضوا في الجايد لاينز بتاعتهم ان ما زال الاوبن ريبير مور سيف في البرانشز دي. ده بقى كلام جديد الحقيقه برضو من البيبرز كانت فيري انترستد، ان الايرلي دايجنوزز اوف جرافت انفكشن في العيان اللي عنده لو جريد فيفر واللي عنده اي ابدومينال سيمبتومز وما عندوش اي حاجه بتبان في النورمال سي تي او الكونفنشال سي تي او ام ار اي، ان البيت سكان الحقيقه بيبتدي يبين فيري ايرلي تشينجز في الانفكشن بتاع الجرافت، ودي الحقيقه حاجه بتفرق جدا في المانجمنت اوف ذا بيشنت. ده الحقيقه برضو كانت بيبر عن الانفكتد جرافت في الفاسكولار اندوفاسكولار سيرجيكال ديبارتمنت في ايطالي. كان بيتكلم على المالتي سنتر ريجستري اوف انفكشن ابدومينال اورتيك ريبير. الايفار انفكشن diagnosis and in open surgery is extremely high mortality rate, and prospective registry could help monitoring outcome in EVAR infection a patient and possibly developing a new survival protocols. Preventive treatment strategy are needed and should be developed in close collaboration with industries. ده الحقيقه بيتكلموا عن ان في شغل معمول كتير جدا على الاوبن سيرجري في الانفكشن، لكن ما عندهمش بيتكلموا على الريجستري بتاع الانفكشن في الايفار، لان دي النهارده بعد ما الايفار بقى له حوالي 20 سنه النهارده ابتدت تظهر حالات فيها انفكشن، وان هم مركزين جدا على الريجستري بتاعتها. ده كان بيتكلم على في الريجستري بتاعه الداتا الانفلونس اوف diabetes mellitus and insulin use on prevalence of aortic aneurysm، والحقيقه الكونكلوجن كان ان هم مش ما بيفرقش معاهم كتير الحقيقه في ده. بقى الحقيقه كانت مفاجاه بالنسبه لي الحقيقه، ان هم عملوا ماسيف ستادي تشوف الكوست افكتفنس اناليسيس اوف اوبن اند اندوفاسكولار ريبير، والكونكلوجن بتاعهم كان ان الاوبن سيرجيكال ريبير از مور كوست افكتيف ذان ايفار. ودي الحقيقه برضو كان حاجه اخر زياره نايجل ستاندفيلد للمعادي كان بيتكلم في نفس الموضوع ده، ان دي معموله، ان الدراسه دي كانت شغاله في انجلترا بقى لها فتره، والكلام كتير جدا في انجلترا على الحته دي. ده برضو بيتكلموا فيها على الري انترفنشن في الاندوفاسكولار فيرسس اوبن ريبير، والحقيقه كانوا بيتكلموا على 467 عيان، في منهم 73 اوبن ريبير والباقي اندوفاسكولار، وكانوا بيتكلموا عن ازاي ان in patient who survive the hospital stay in re-intervention free survivor is much lower after EVAR. ودي حاجه برضو من الحاجات الحقيقه اللي خدت ديسكشن كتير جدا في المناقشه، لان ما زال في very strong school في اوروبا بتسبورت جدا الاوبن ريبير، وشايفه ان الري انترفنشن اقل بكتير من الايفار. لكن الدراسه دي الحقيقه على ماسيف نمبر اوف كيسز في نيذرلاند في هولندا اكدت انها مور مع الاوبن. ده بيتكلم عن البوست امبلانتيشن انفلاماتوري ريسبونس في الايفار افتر ابدومينال اورتيك انيوريزم ريبير، ودي الحقيقه بتكسبلين الان اكسبليند فيفر اللي بتحصل للعيانين دول بعد الايفار. ده بيتكلم برضو عن الستاندرد اوف سوبرا رينال فيكسيشن، وان النك نزلت لحد من 5 ل 10 ملم دلوقتي بيقدروا يحطوا الايفار مهما كانت النك صغيره دلوقتي بقى مع التكنولوجي. برضو دي من البيبرز الحقيقه اللي كان عليها a lot of discussion في الكاروتيد، ان الارجنت كاروتيد ستنتنج does not increase the risk of pre-procedural complication. ده الحقيقه دي اتعملت في السويدن واتعملت على large number of cases على 269 عيان على مدى 8 سنين. بيتعمل لهم الكاروتيد ستنت within the first 24 hours زي الكورونري، زي الاكيوت كورونري سيندروم. ورغم ان كان كل الاستاديز بتقول ان ده بيتزود جدا الريفاسكولايزيشن انجري، لكن الاستادي على الماسيف نمبر ده اكدت ان في اي وقت بعد الترانزيت اسكيميك اتاك ممكن نقدر نعمل الريبير. دي الحقيقه كانت بتتكلم عن الهايبر في الانترميتنت كلوتيكيشن واهميتها في الكاروتيد الايليك ستنت مع انسايتوفين جرافت. ودي برضو دي بقى حاجه برضو من الحاجات الحقيقه اللي اتكلموا فيها كتير جدا، وانا حابب ان انا اوصل لكم الرساله دي، ان الشركات العالميه دلوقتي عايزه من السوسايتيز النون سوسايتيز انهم يبعتوا لها ريبورت سنوي عن كل الادفيرس افكت اللي بتحصل من الستنت، خاصه الاس اف اي ستنت، سواء الفراكشر او الاوكلوجن او المايجريشن او الحاجات دي لازم تتجمع وتتبعت للشركات مجمعه من الجمعيات، لان ده ابتدى يغير وابتدوا يعوضوا السنترز بستنتس ثانيه بدل الستنتس. والحقيقه اللي قدم المحاضره دي كانت احد الشركات المشاركه في المؤتمر. اخر حاجه الحقيقه ان في استادي اتعملت في انجلترا عن الافكت اوف راديشن على الهيد. احنا كلنا مركزين في ان احنا بنلبس البروتكشن على البادي وعلى النك وعلى الكلام ده، لكن الحقيقه الاستادي دي كانت الحقيقه استادي ملفته للنظر جدا، ان خاصه مع الانجوليشن اوف ذا سي ار في مرحله معينه وانت بتشتغل الراديشن على الهيد الحقيقه عليها كلام كتير جدا جدا، ولابد ان هم يشوفوا لها حل. ودي مش الحقيقه حاجه لابد ان تطرح مع الشركات، ازاي يشوفوا حل بروتكشن للهيد، خاصه ان دلوقتي البروسيدجرز بقى بتاخد وقت اطول وبقى في حاجات كتير جدا بتتعمل بال الحقيقه الكونكلوجن انا قلت في وسط الكلام مش هحتاج اقوله تاني. شكرا جزيلا.
Thank you very much, Dr. Hassan Al-Nadi. We'll open the floor only for 2 questions for the time limit.
بسم الله الرحمن الرحيم. أنا شاكر جدا السادة المنظمين، شاكر الدكتور بدري الحسني، الدكتور عمرو بيه فاروق، أشكركم جميعا. أنا سعيد جدا مستوى الرقي بتاع البرزنتيشن اللي احنا سمعناه النهارده والعلم الغزير اللي احنا تعلمنا منه. الحقيقة الدكتور عصام بيه قال لنا ملخص عظيم جدا مجموعة بيبرز منوعة. الحقيقة كل بيبر منهم عوضتها عدة طويلة يعني ديسكشن طويل، لكن أنا هختصر وأسأل. أنا الحقيقة الحاجة الأولانية هي الإمرجنسي يعني احنا العلم بتاع المناوي اللي احنا بنعمله بنقول لهم لا ده ممكن نعملها مراجع كفار عندنا بشكل كبير.
والله يا دكتور ممدوح بيه الموضوع ده كان حصل يعني التوك دي حصل عليها ديسكشن جامد جدا في المؤتمر، وكان في ناس كتير جدا من دي كانت مفاجاه بالنسبه لي الحقيقه، عشان كده انا حطيتها في ان لقيت ان الناس كتير جدا مؤيدين الفيري ايرلي انترفنشن، خاصه بتوع امريكا كانوا مؤيدين جدا للفكر ده. وكان في اكتر من استادي اتكلموا عليها، انها الحقيقه لما تشوف البيبر نفسها، الحقيقه حضرتك لو رحت على الويب سايت بتاع اليوروبيان فاسكولار سوسايتي هتلاقي البيبر الحقيقه فيري امبرسيف في ان هم طبعا ما بيشتغلوش اول 24 ساعه، لكن في حالات من الاستادي معموله within 48 اور within 24 hours، لكن هو كان كل الكلام ان نقدر خلال الاسبوعين الاولانيين ان احنا نعمل، بل بالعكس ان الكلام كله كان ان الريزلت بتبقى ماتش بيتر لما بتبقى ايرلي، وده عكس تماما فعلا اللي احنا اتربينا عليه من الريفاسكولاريزيشن انجري والحاجات دي. ان شاء الله.
الحاجه الثانيه برضه شفت جدا الكومباريزون بين اوبن في ناس مع الاوبن كبير هو هو على الجراج ممكن في شغل علامه استفهام كبيره جدا.
والله هو الحقيقه الكلام البيبر دي كانت في انجلترا، والحقيقه ده الكلام اللي انا كنت سامعه من الكونسلتنت الانجليز في اكتر من مناسبه، ان كل الاستاديز اللي شغاله في انجلترا بتؤكد، لان الري انترفنشن في الاندوفاسكولار في الفار او التيفار بيبقى مكلف جدا، واخد بال سيادتك؟ الحاجات بقت غاليه جدا، الفنستريت جرافت والبرانش جرافت والحاجات دي، فاي ري انترفنشن بيبقى كل حاجه بثمن. الانجليز بيحسبوها بالمليم الحقيقه، فهم ما زالوا شايفين لحد النهارده، لان الانجليز برضو اولد فاشن سيرجن، يعني لحد دلوقتي دكاتره الفاسكولار معظم السينيورز فاسكولار سيرجن في انجلترا ما بيشتغلوش اندوفاسكولار خالص، يعني النيو جنريشن بس اللي بدات تشتغل اندوفاسكولار، ما زال الاندوفاسكولار بيتعمل بالاشعه لحد دلوقتي في انجلترا. فهم الحقيقه الدراسه بتؤكد هذا في اكثر من سنه.
This is a question for Dr. Wasila, but before this I have a very short comment that on the same, you are talking about the cost effectiveness and the midterm results of cell plans between rupture and between aortic aneurysm and valve in rupture.
Yes.
But actually, we have to look on the short-term result, still the rupture, the early survival is very appreciated because much difference between intervening with someone with rupture and you solve the problem in half an hour by uni-aortic graft. It saves the patient, but all of us know that still rupture will have a very high mortality.
Absolutely, I absolutely agree with you.
Thank you very much, Dr. Asad, for this excellent companion and people where we do this supplement. Thank you very much. I have a comment and a question. My question about the screening of the PVD, as you told us that you know the deep debate about how to measure outward to outer inner.
بالضبط دي.
Outward to outer it's well established why because inner to inner is pure formali and the pure formali are not never ever uniform.
بالضبط.
We cannot judge the measure of the PVD about the inner. As you know, it's not very concentric. Sometimes the big valve of the pure formali level, another level, they are much thinner, so they not even take an accurate measurement about it. But let's establish this is an outer to outer, and we have to follow very clearly according to the movement. And put an important point about the anteroposterior diameter and the content diameter. It's a big mistake because most of the vascular head they do provide only the content diameter. We have to put also the anteroposterior diameter because this is the most important according to the shear stress and the shear pressure. This is my comment. About the registry, we think we need now a registry for the PVD or another sub-question if you allow me. We have a prevalence of the PVD in our community as in Western countries. What do you think about this? Because it's a totally different pathology. It's not an atherosclerotic disease, not an atherosclerotic pathology as our fragile identification and so on. What do you think about the real prevalence of PVD in our country?
Thank you, Dr. Wasila, for this question. Actually, I don't think we have the prevalence of the AAA like Europe, actually. So I'm not very keen to have a screening program like Europe and the States for this, but I am very keen to have registry of our endovascular repair of the aorta, either thoraco-abdominal or thoracic or abdominal. Because actually we, as I said before, we are working in different isolated islands and we don't know anything about what's happening. We need to have some sort of pooling of these cases, even in registry, to know what exactly we are in, where our position exactly and honestly from this technology. Thank you very much.
Thank you, Dr. Hassan. Now we move to the second talk. Professor Dr. Fatih Ali, I think he is very well known to you, and we talk about evaluating little by frequency.
كده نتحرك من هنا. Okay. Mr. Chairman, dear colleagues, first I would like to thank Professor Al-Aisawi and my friend Dr. Omar Farouk for inviting me in this elegant conference or meeting. And you may excuse me because I have a topic which is gloomy, actually. Despite it is a rare complication, but it gathered a lot of interest because it's complicated or bad outcome. When you think you successfully deployed or excluded at type B dissection successfully, and then you end up with acute cardiac tamponade, possibly, and if you are lucky enough to get something to get the patient fast to surgery, your patient may do well. But in the majority of cases, those patients die very quickly. And once you get acute cardiac tamponade, you won't be able to do anything fast to get or try to stop the blood. This is what usually happens. I quote this from Professor Nienaber. Please, أبعديه لو سمحت. Okay, and okay. So this is here. There is a successful exclusion of a type B dissection. Note that this is the false lumen. It still became patent in front of the descending aorta, and in the majority of cases, it is continuous with the false lumen distally with a new entry tear. And here what happens for retrograde type A dissection? And a new entry tear starts in the vicinity of the left subclavian artery and left common carotid, and then dissection propagates into remaining of the aortic arch and the ascending aorta. And this is usually start at the bare spring part in the proximal stent graft. Quickly, this is some of the etiologies, or I will go back this later. But you have to know that many cases are related to your procedure, to your device, and your manipulation of your device. If you come back to the literature to see what is associated with this complication, and actually it breaks up that to about 42 articles. We don't have it on my slide because the outcome is gloomy, as I mentioned. It breaks up that most or all the devices available in the market, especially the old design devices, had reports of retrograde type A dissection, and most commonly, again, starting from the area of the bare spring of the stent graft. The incidence, you may have many reports ranging from 1.5 to up to 6.8%, but the largest single center report came from Harvard, UCLA, but reported an incidence of 2.5%. And the European Registry on Endovascular Aortic Repair, they had an incidence of around 1.3 or 1.5. And here are the etiology. This may be a procedure related, manipulating your devices, your catheters, wires, especially back and forth in the area of the aortic arch, or doing repeated balloon dilatation for just conforming the shape of your stent in the arch, that you may end up with trouble. It might be also anatomy related, either the bovine arch, you know that, or the need, or when you have to cover the origin of the left subclavian or left common carotid artery with your stent graft. And you have to look for also the patency status of the false lumen. And sometimes it is related to the natural progression of the aortic wall. It's usually fragile at this segment of the aorta. But most commonly it is device related, the design feature of the stent, your stent, whether it's related to the longitudinal support or how much radial force your stent is providing against the aortic wall, and also the risk of the presence of a new entry tear from usually starting from the bare proximal spring, as I will show you in a moment. And in the large single center series, they had 11 entry tears after type B dissection, exclusion of type B dissection. 9 of the 11 entry tears occurred at the tip of the proximal bare spring. These are the risk factors of this complication. Mostly it is the exclusion of type B dissection, especially when it's done at an acute situation. And these are the other risk factors. I will not go through that. This is a sub-analysis of a report from the European Registry looking into the mortality in relation to the onset of retrograde type A dissection. And they found that when it happened during the procedure, after excluding the type B dissection, those patients are the most will eventually die very quickly compared to those who passed the procedure and then they had the type A dissection later on. Around 50% of the cases are related to the bare spring of your proximal stent graft. This is the one of the largest series coming from Harvard, UCLA, as I mentioned, for retrograde type A dissection. They had 6 cases and 400 thoracic cases. That's about 1.5%. The 6 cases are divided into 3 had the complication intra-procedure related to either the stent or the balloon dilatation. 2 cases had the wire or catheter perforation, and 1 case had the progression of the usual pathology, original pathology, and the aortic arch. Let me show you some cases. This is a 53-year-old female with 3 weeks having tearing chest pains for 3 weeks, and also had uncontrolled hypertension. This is the pre-procedure. You can see the intimate lab over here. This is a 3-dimensional color reconstruction. This is pre-procedure. And then 8 hours after fixing the type A dissection, you had this rupture in the aorta starting from here, and this patient actually didn't make it. Okay. And this is during the operation. You're trying to save the patient, and you can see this is the hemorrhagic blood. This is the adhesion into the lung, the left lung. Another case. This is the descending aortic aneurysm here, just after the distal to the origin of the left subclavian artery. And look here how you can input or impose damage. This is the stent, and you can see that this is the proximal endothelium getting into the origin of the innominate artery, and this is the aneurysm. Look what happened. Then they deployed the stent again, and the device has gone too far into the innominate. then covering also the left internal common carotid artery. There's some here. You then had trying to solve this, what's supposed to be a leak. Then we did a balloon dilatation, and you can see what's going on up here. Let me show you. We cardiologists like IVUS very much because we are accustomed to this image. This is the intravascular ultrasound. This is the catheter. This is the lumen, and this is the stents here in this segment. This is the stent struts, and this is normal here. This is the origin of the right coronary artery, and then but now here, look at this. This is the bear spring. It comes as like a stick over here, getting into the origin here of the innominate artery. You can see on this side also here, this is struts of the stent, one lumen, another lumen. This is the section over here. We cannot see the intimal flap round here. And this is the original aneurysm here. This is the true lumen, this is the false lumen. Actually, this patient has been fixed. Right, okay. All right. Another case for retrograde dissection following TVAR. This was part of the Valor trials, 65 years old female with enlarging descending thoracic aneurysm. It's here. And look at here. Again, same mistake. Right? So this is again the stent coming over here and fix it, and then 5 days later, this is what happened. Acute cardiac tamponade. This is during the surgery. Actually, the surgeon tried to save the patient in vain. And what happened here? Wire perforation in the ascending aorta while manipulating your device, the wires here, and this is a nominate artery dissection of what is a post-mortem force. Maybe this I'll go through this quickly. 75 years old male with enlarging descending thoracic aneurysm. Again, there's no angio for him here. This is again three-dimensional reconstruction, CT reconstruction. Again, had rupture after fixing the aneurysm, and this is again wire perforation in this aneurysm. All right. Okay. We go to this. Sorry for that. I will go through this. This is how when you have a dissection over here, we have a dissection here. You can see the spiral dissection. Actually, you can see it in this three-dimensional reconstruction here, starting distal to the left subclavian, going down to the abdominal aorta. And here, again, same mistake. This is your device getting too far into the origin of the innominate or brachiocephalic artery. You can see here is again two lumen, one, and this is the descending flap here. This is again part of the false lumen going down to the abdomen. This is now we start to see the intimal flap over here and over here. Let me show you some more, and actually extending down to the celiac artery. Again, this is the intimal flap. Actually, you can hear. For the first time, you realize that the catheter inside is coming from the false lumen. This is superior mesenteric artery. Again, this is the renal artery. Here again, you can see again the intimal flap. And looking back to the same patient after deployment of the stent, again, this is the bear spring here, and this is starting the origin of the brachiocephalic artery. And here, when you do some dilatation here, you can see the stent crumbled here, but this is another lumen. Again, the same in this part at the left origin. Here is the origin of the left subclavian. This is the stent again obstructing its the takeoff here, and this is in the abdomen. This is intimate flap, true lumen. This is the false lumen. And just to show you this, some picture, I can move on. This is the patient actually was fixed. Okay, well, I can show you again. This is another stent over here, and again this is two lumen. This is actually it's a transesophageal echo, and this is by surgery. The patient was saved, but this is the wire perforation, and here is this shape we found. This is the bare metal stent spring at the proximal end of the stent, and you can see how it fixes on inside the aortic wall, and this is how actually what happens. To treat this patient, usually the only way to save the patient is to fast or prompt surgical conversion, and some reports came with successful medical treatment in more, I think, in more stable conditions. I have to be here. And in the Euro registry, the method of treatment basically based on the timing of the section in relation to the index T-bar. The most important thing is to prevent this, otherwise you will not succeed. Continuous surveillance of T-bar patient and careful patient device procedure. And I need one more minute, please. One more minute. That's okay. And especially patient with Marfan, actually Marfan syndrome is contraindicated to deploy a stent in the aortic arch. And be careful about kinked aortic arch, and try to, if you have to, or you have doubts about fragile aortic arch, try to deploy it without the proximal spring or barbs. And you have to be most important to avoid pushing forward on a partially released stent graft. We usually when deploying our stent, we partially deploy it on the very proximal part, and in the trial to pull it back sometimes a little bit more distally, but sometimes we push forward. This is very dangerous, and you may pull this type of tear. And to conclude, the retrograde type A dissection, the incidence is rare complication, but it's gloomy. So I pray 1 to 2% of thoracic endograft procedures. It's associated with ileal balloon dilatation. This is difficult anatomy. Be careful in such circumstances. And about 30 to 40% are related to wire or catheter injuries. And it is reported with all proximal device designs. But we need more studies to document the etiology, the real etiology of this complication, and whether it may impact the future design of the recently introduced stent devices. Thank you for your attention.
Thank you, Professor Barbai. Okay, I will take this part, and could I ask you to have a product section and
dissection where? And the type B dissection.
Type B.
Okay.
Type B dissection, and you fix it part of it, and you still have the false lumen.
Going down to the distal stent. Yes, we follow it up. We follow it up because usually this false lumen will be squeezed by the stent, and then eventually it will collapse in the future. So we have to follow up those patients.
So for how long do you wait until
My first CT scan would be after 3 months, unless there is complications. And we are going. Thank you. Thank you.
Thank you.
It's always right between innovation and efficiency. Today we go with innovation. Dr. Amar Modu will give a scientific outlet, and then we will do the validation to prepare MT.
Thank you, Mr. Chairman. First, I'd like to thank Dr. Omar Farouk to give me the opportunity today to speak here. And my talk is about retrograde decolonization of aberrant posterior tibial artery as case presentation. So our patient was male patient, 73 years old age. His complaint was heel ulcers with stage necrosis. The risk factor for this patient was diabetes, type 2 diabetes, hypertension, ischemic heart disease with history of CABG. The general examination for this patient was well and good, while the local examination showed patient with palpable femoral antipopliteal pulse. However, the pedal and distal pulses were absent. So the clinical situation of this patient gave an impression that we have patient with critical limb ischemia and almost infrapopliteal tibial artery disease. Although the patient has normal kidney function, but based on the duplex scan of being a non-invasive diagnostic tool, so we asked only for high-quality arterial duplex scan that showed, as we see here, patency of arterial tree extend from the infrarenal aorta down to the distal popliteal artery with no evidence of hemodynamically significant stenosis occlusion. And also showed severe infrapopliteal tibial artery occlusive disease. We have here occluded tibioperoneal trunk. We have occlusion in the proximal part of posterior tibial artery. We have severely attenuated and diseased peroneal artery. We have only short segment at the origin of anterior tibial artery, then down as in get occluded down to the dorsalis pedis artery. So based on the duplex information, we have only one distal running down to the foot. So it is really precious artery to save the foot of the patient. So our plan here is to do endovascular recanalization for the proximal part of posterior tibial artery and the tibioperoneal trunk. So trying to achieve straight inline flow in direct continuity with the foot. So we start our procedure here with the ipsilateral antegrade femoral axis guided by duplex ultrasound. Then we did angiogram here. شغل فيديو تاني بقى. حاولت ان انا كنت هنجي خالص وانا اكمل على سوق. Didn't work. The same. So I have a problem with movie file here.
اوكي
سنة
تقدر تجيبها اصل هو قال كمان بلاي موفي مش مسألة تسبيك ارجع بقى برزنتيشن وعدي السلايد اللي بعديها فاضيين
كل بسرعة موفي فايل كله
مش هتتعلم قبل كده ده
بره.
اوكي اتكلم بيبينوا هنا اتس اوكي مش مشكلة.
So this is a
cannot play video.
Here we did an angiogram and it shows the same result of duplex finding. So we started the recanalization from antegrade approach. using 0.014 wire supported by hydrophilic microcatheter, CXI from Cook, but repeated attempt of crossing from antegrade failed and end with perforation. So we shift for retrograde access. Here, we did retrograde access through the distal posterior tibial artery guided by duplex ultrasound, and we secure our access by micropuncture kits from Cook. Then we start crossing the lesion from below using the same tool, 0.014 wire supported by hydrophilic microcatheter. Then we, with repeated attempt of crossing to the lesion, we make sure that the wire going through the true lumen of the artery, and accidentally we find that the wire and the catheter going up to the proximal part of the popliteal artery just above the knee. Then we did angioplasty with low profile tibial balloon, 3 millimeter, 20 centimeter, and here the final angiogram here. And final angiogram here showed the abnormal course of posterior tibial artery with high origin from the proximal posterior popliteal artery. It is a typical tibial variant. Then after doing angioplasty for the proximal part of posterior tibial artery, we get antegrade wiring and they insert balloon from the antegrade axis, and we then inflate a balloon just distal to the level of sheath entry, and we do balloon angioplasty just to close the distal axis side. So the message here from this case, that retrograde access was very important because it achieved a successful recognition of the posterior tibial artery, and without the retrograde access, the antegrade axis alone failed to identify this variant. When going to the review of literature, here an example for the tibial variant. We have trifurcation here. We have the high takeoff of anterior tibial artery and the high takeoff of posterior tibial artery. I will try in a few minutes to cover the following items: indication, material, and steps of retrograde decolonization, and what are the evidence and the fact of retrograde decolonization. Indication for retrograde decolonization: morbid obese patient may be a challenging case for antegrade access, failed antegrade decolonization, patient with hostile and discarded groin, flush SFA occlusion, flush tibial occlusion, distal popliteal occlusion, and if we have patient with multi-level peripheral arterial disease extend down to the tibial vessels. But why the antegrade fail? Antegrade failure has been reported to be about 20 to 25% of cases. The antegrade fail that because we have a lot of CTO in our practice, and usually the proximal cap of the occlusion is more firm and more resistant for wire penetration, while the distal end of the occlusion is more soft. Theoretically, the occlusion can be easily decolonized from retrograde abortion. And even if we succeed to pass through the whole occlusion from antegrade axis through subintimal plane, sometimes it can be very difficult to get re-entry to the true lumen. Of course, re-entry device can help to overcome this step, but unfortunately, it is not always available in the angio suite, and it's really expensive. So at that time, we have to search for alternative and assembled axis. And one of that is the retrograde axis. The axis site can be one of the following: can be the popliteal artery, anterior tibial artery, posterior tibial artery, and peroneal artery at different zone of the leg, and also through dorsalis pedis, and also through transcollateral. Not only that, but Marco Manzi and Luis Mariano from Italy showed an indication for the extreme retrograde axis. That because we have a lot of patients with severe tibial artery disease that extend down to the level of ankle, and this can cause a limitation for the typical and standard retrograde axis. And they start to publish their data in the last 2 to 3 years about the feasibility and the safety of extreme retrograde axis. And I will show the result at the last section of my presentation. Here an example for this patient. This patient has trophic change at the big and 32, and according to the angiosome distribution of the ischemic lesion, we have to recognize the anterior tibial artery and the dorsalis pedis artery. They report that there was antegrade failure, so and the typical transpedal axis was failed because it was severely diseased, so they get an access through the first metatarsal digital branches. Another example for this patient, this patient has severe PTA disease just behind the medial malleoli, with failed antegrade decolonization and also failed and beta plantar loop technique, so they get an access through the lateral plantar branches. But before going to do retrograde axis, good experience is needed, especially for the distal tibial axis and the extreme retrograde axis. That's because we have a small size vessels, we have low flow in the distal arterial bed, so we have also the risk of arterial wall and the vessel wall damage, and this can jeopardize and compromise the foot circulation and can lead to serious worsening of the ischemic condition to the foot. So very important issue to be considered here is the balance between the risk and the benefit ratio for your patient, especially if you have the option to do future distal bypass surgery, and I think our patient was a good example for that. Here the retrograde axis can be one of the following, can be percutaneously and the surgical pedal axis, but for sure surgical pedal axis is unfavorable. The percutaneous axis, you can guide your axis by fluoroscopy, looking direct for the calcification, by a combination of fluoroscopy and contrast, and through roadmap injection from the antegrade catheter. But all this step means more radiation exposure, more volume of contrast, so the best one is the duplex guided axis. And you can see in this trial, the femoral arterial axis with ultrasound trial, it was prospective randomized controlled trial. About 1,000 patients were enrolled with 1:1 ratio between fluoroscopy and ultrasound guidance. And they conclude, based on the result, that ultrasound guide can improve the common femoral artery cannulation only in patients with high bifurcation, can reduce the number of attempts, can reduce the time to the axis, can reduce the vein puncture, and with minimal vascular complication. So I will pass this step. I think we have for retrograde recanalization, we need axis from above and the axis from below. Then you start the crossing to the region, try to be interluminally, but if it failed, you can go subintimally, and you can continue the dissection from above and below. But one of this technique, either bidirectional wire, double balloon technique, or retrograde balloons supported or assisted by re-enter device from above. Here, some studies that shows that combined antegrade and retrograde recanalization is established technique for treatment of peripheral arterial disease. Here is a safari technique. They show it in the result about technical success about 100%, with limb salvage about 90% at 6 months. Also, here is the result of about the feasibility and the safety of transmetatarsal artery axis in complex cases of critical limb ischemia. In that study, about 38 patients were enrolled in that study. The technical success was achieved in 86% of cases, with improvement in the transcutaneous oxygen tension. The amputation-free survival was about 84% at 12 months. But with the major limitation in their study that there was high radiation exposure and retrograde approach. So like CART technique described for retrograde decolonization of coronary artery, we have also safari technique described for retrograde decolonization of peripheral artery. So conclusion, Mr. Chairman, retrograde axis is safe technique and it can be applied on pillow basis in case of antegrade failure. Combined antegrade and retrograde approach can improve the technical success up to 90% of cases. Operator experience and the choice of right material are the key for successful retrograde decolonization. And of course, if we have patient with feet like that, we have to remember that revascularization is only one step in diabetic foot diabetic foot CLI treatment. And the limb salvage needs a multidisciplinary approach model, and the teamwork, including diabetologist, vascular surgeon, and the foot surgeon, is the key for the best outcome for your patient. And thank you.
if there's no picture, I will wrap one more comment. Thank you that you said the temperature is 100% successful. But please add the experience so it's not for anyone to say yes, it's easy procedure.
في النهاية شكراً. زي ما توقعت بالنسبة أحسن من الأربعة. الحقيقة لازم نأكد على رسالة مهمة عن الدكتورة سامي الأرض. قلنا إن إحنا بنشتغل في سيفل ايلاندز. الرسالة دي لنا لازم الايلاندز دي تتحد مع بعض. لازم مش كفاية أبدا إن إحنا نستخدم الكون. لازم يكون في فيلد بيزنس. لازم الناس تعرف بعض أكتر، تاخد بعض في السكن بتاعها. ممكن قوي بدل ما نعمل أبحاث على 30 40 عيان لو التعاون بيننا وبين بعض أكتر 100 و200 عيان يبقى الشغل بتاعنا بيبقى له أكتر. الرسالة الثانية بقى للدكتورة سامي برضه إن مفيش حاجة قاعدة مسلم بيها نحفظها كده ولسه ما جاتش. لا، في إعادة نظر الأبحاث كده، الأبحاث المسلم بيها ونقراها بأوبن مايند ونشوف هل ده الكلام ده يعني نقدر نعيد مرة واثنين وثلاثة نفس النتائج دي ولا في اختلاف شوية ولازم نراجع نفسنا. نعم أريد الشكر لحضراتكم سعداء بالتواجد معكم في هذا المكان. شكرا جزيلا.
Thank you very much. The next session will be session number 8, and the chairperson, Professor Ayman Abelmet. And this will be one of the very fascinating lecture that you will ever hear. It have a huge impact about cardiologist, interventionist, and vascular surgeon by Professor Nabil Farag. Going to discuss the new oral anticoagulation in the stroke prevention of atrial fibrillation.
بسم الله الرحمن الرحيم. احنا موضوع النهارده هو حاجه من حاجات النيو انتي كواجولانتس فور ستروك بريفنشن ان بيشنتس ويز اتريال فابريليشن. طبعا احنا كلنا عارفين ان الوارفرين هو طبعا الكورنر ستون في از ان انتي كواجولانتس تو بريفنت ستروك ان بيشنتس ويز اتريال فابريليشن. والوارفرين ده از ا فيري اولد دراج وله طبعا سايد افكتس وليميتيشنز كتير قوي. عشان كده بدانا نفكر في النيو انتي كواجولانتس اللي هنتكلم عليها دلوقتي. لو هندي اوفر فيو عن البرزنتيشن اللي انا هقولها، اول حاجه احنا بنتكلم على البيردن of the disease associated with atrial fibrillation and atrial fibrillation related stroke. هنتكلم على الابيديميولوجي of atrial fibrillation and stroke worldwide، وهنتكلم على الابيديميولوجي in Africa and Middle East، وهنريفير ده to Egypt. هنتكلم بسرعه مش بتفاصيل كتيره في الجايد لاينز فور بريفنتنج ستروك ان بيشنتس with non-valvular atrial fibrillation. واخر حاجه هنتكلم على النوفال انتي اورال انتي كواجولانتس in stroke prevention in patients with atrial fibrillation. لما نيجي نتكلم على burden of the disease، ان الجلوبال burden of atrial fibrillation is increasing every year، وان individuals over the age of 40 years have a 25% lifetime risk of developing AF. والAF بينكريز الريسك اوف ستروك 5 فولد، وبالتالي الستروك بتدبلز المورتاليتي ريت. not only the stroke is associated with atrial fibrillation, but also the different forms and of dementia are linked with atrial fibrillation. فعندنا non-specific dementia, Alzheimer, senile and vascular dementia. All of these also are linked to atrial fibrillation. The problem is that as we are getting older, the prevalence of atrial fibrillation increases. Not only atrial fibrillation increase, but also the strokes related to this serious arrhythmia increase with age. And it is very common to find patients over the age of 80 to have atrial fibrillation, and they have a great instance of developing a stroke due to this arrhythmia. Unfortunately, low-income countries had a 3.5-fold increase in stroke mortality compared with middle and high-income countries, maybe due to the emergency in manage stroke patients in their center. They manage it better than in our center in poor or low-income countries. Regarding the epidemiology of atrial fibrillation, the atrial fibrillation globally is about 1% of the population, and from hospital-based study, it's about 3 to 14% of the population. For example, in North America and Europe, the atrial fibrillation represents from 1 to 2% of the population. And again, it is very common in elderly patients, as it represents about 88% of people over 80 years age. Regarding the prevalence of atrial fibrillation in the Middle East, we can find that in a country like Bahrain, we found that patients coming to the emergency room, about 3.4% have atrial fibrillation. And in Kuwaiti hospital emergency room, the prevalence is about 4.2%. Actually, we don't have statistics regarding the prevalence of atrial fibrillation in Egypt, but we can roughly say that about 1% of the population have this bad arrhythmia, and 1% of 7 billion, so we have 70 million people worldwide has atrial fibrillation. And 1% of the total population of Egypt, of about 80 million, represents about 800,000 patients with atrial fibrillation, with more than 100,000 present in Cairo. AF is associated with increased morbidity and mortality, with stroke being the most serious complication of AF. Regarding the Middle East and Africa, in the RELY AF registry, in the Middle East, the stroke related to atrial fibrillation represents less than 4%. And in Africa, the crude stroke rate related to atrial fibrillation reaches to about 8%, which is a very big number. But when corrected to age, the stroke rate is about 4%, which is equal to that of the Middle East. A very important scoring system that is applied in Europe, and we apply this scoring system in Egypt, which is a SHADS-VASC score. The SHADS score is a very common score. We all know it, and this score, it gives points to every item. For example, for congestive heart failure, it's 1 point. For hypertension is another point. For age above 75, in the SHADS score, it takes 1 point, only 1 point. Diabetes mellitus 1 point. Stroke TIA and thromboembolism is 2 points, with a total score of 6 points. And this is the VASC, the vascular disease, age between 65 and 74, and female 6. When we add this, we call it SHADS-VASC score. The difference is that here the age above 75 is 1 point, but in SHADS-VASC score, age above 75, it takes 2 points. In addition to the presence of vascular disease added 1 point, age between 65 and 74, another 1 point, female 6 is another point. And according to this score, we classify patients into low, intermediate, and high risk patients for developing stroke due to atrial fibrillation. The low risk patients who has score of 0, and intermediate risk patients who have score of 1, and high risk patients who have a score of 2 or more. What about the guidelines for preventing AF-related stroke? We have the European Society of Cardiology guidelines, which depends mainly on the CHES-VASC score. And as I said, it classified patients into high-risk patients, intermediate risk patients, and low-risk patients. For high-risk patients with CHED score of 2 or more, oral anticoagulants is mandatory, is highly indicated. وهنا is class 1 with level of evidence A. In patients who are not eligible for vitamin K antagonist warfarin due to many reasons, we will discuss these reasons later on. These patients are subjective to one of the 3 new anticoagulants, dabigatran, rivaroxaban, or apixaban. In moderate or intermediate risk patients, oral anticoagulants is indicated with class 2A level of evidence A, and low risk patients, we don't need any oral anticoagulants in such patients. There is some difference between the European Society of Cardiology guidelines and the American Stroke Association is that in high-risk patients, warfarin is indicated, or alternative, the novel or the new oral anticoagulants. And in patients unsuitable for vitamin K antagonists, we can give clopidogrel plus aspirin. And in moderate or intermediate risk patients, they take the vitamin K antagonists, and in low-risk patients, they give just aspirin. What is the problem we face with warfarin? There is still unmet needs with the current treatments with warfarin. We'll discuss this. Despite the guideline recommendations that patients at high risk should receive oral anticoagulants, this is what we find in the different registries, especially in the RELIASE AF registry. If we look at this column, this is a high-risk patients with CHES score of 2 or more. We can see that this is patients who are not taking warfarin, but taking antiplatelets. And these are the patients who are taking neither warfarin nor antiplatelets. And this represents about 47% of patients who are in need for these oral anticoagulants, about 0.5% of the patients who are at high risk of developing stroke, actually, they didn't receive the oral anticoagulant, and this is a big problem. Again, in the Middle East and Africa, in Middle East, about 40% of the patients with CHED score of 2 or more, that means that they are at high risk of developing stroke due to atrial fibrillation, they don't receive the oral anticoagulants. And in Africa, about 60% of the patients, they didn't receive these oral anticoagulants. Another important message we got from the vitamin K antagonists is that even patients who received these oral anticoagulants are not at the goal. At the goal means they are not in the therapeutic range of INR between 2 and 3. We can find that in Middle East, only about 47% are in the range, in the therapeutic range of INR between 2 and 3, and a good number of patients are undercoagulated. Another number of patients are overcoagulated, and this also applies to Africa, with only 40% are in the range between 2 and 3. And this also carries a big hazard. Either development of stroke or development of bleeding due to the over anticoagulation. And this study who classified patients into 3 categories and 3 groups according to the therapeutic range or time in therapeutic range. Time in therapeutic range means المريض قد ايه في حياته قاعد الاي ان ار بتاعه كنترول. فلو احنا عندنا التايم ان ثيرابيوتيك رينج اقل من 60% دول بيسموهم بور كنترول. وبور كنترول هنا معناها either over or under coagulated. moderate control اللي هو التايم ان ثيرابيوتيك رينج between 60 and 75%. الجود كنترول اللي هو التايم ان ثيرابيوتيك رينج more than 75%. If we look here at the poor control patients, we can find that the mortality is significantly much higher than those in the moderate control and good control patients, and this mortality increase is due to the increase in the incidence of stroke as well as increase in the incidence of bleeding. As we said before, poor control means that the patients are either under coagulated or over coagulated. Under coagulated patients are at risk of developing stroke. Overcoagulated patients are at risk of bleeding complications. Now we come to the novel oral anticoagulants. We have actually 4 new oral anticoagulants. The first 3 inhibits activated factor 10, and these are the apixaban, rivaroxaban, and edoxaban. And the fourth one, which is oral direct thrombin inhibitor, is the dabigatran. And these are the landmark clinical trials regarding the 4 new oral anticoagulants, and all of these trials addresses 2 things: efficacy and safety. Efficacy means it is effective in stroke prevention, and safety addressing bleeding complications. The first trial in 2009 was a RELY trial comparing dabigatran in 2 different doses, 110, 150 against warfarin. And in 2011 we have the AFIROS trial comparing aspirin with apixaban, and ROCKET AF trial comparing rivaroxaban with warfarin, and Aristotle trial comparing apixaban again with warfarin. So we have 2 trials regarding apixaban, the first one comparing it with aspirin, and the second one comparing it with a traditional treatment anticoagulant warfarin. And recently in 2013, the ENGAGE trial comparing edoxaban with warfarin. And all of these trials again addressing efficacy and safety. So if we go to the RELY trial comparing dabigatran in 2 different doses, in dose 110 and 150 against warfarin, we can say that 150 milligram of dabigatran is much more effective in stroke prevention than warfarin and dabigatran 110 milligram. But this effective prevention of stroke was at the expense of developing of major bleeding. So we can see here that dabigatran 150 milligram is associated with higher bleeding complications than dabigatran 110. So dabigatran 110 is effective in preventing stroke, but not like dabigatran 150, but is much more safer than dabigatran 150. And again, the AVIROS trial comparing apixaban with aspirin in stroke and systemic embolization prevention. طبعا there is a highly significant difference between apixaban and aspirin in preventing stroke and systemic embolization. And the major bleeding, there was no significant difference between both. The total death was in favor, was not statistically significant, but was in favor of apixaban over aspirin. These patients who were taking aspirin because of these reasons, either assessment of INR could not or was unlikely to be measured, or the patient was refusing taking the vitamin K antagonist warfarin, or the SHAD score was 1 and the physician was advising the patients to take aspirin. This is the reasons why these patients were not taking the vitamin K antagonists. The third landmark clinical trial is the ROCKET-AF trial. The ROCKET-AF trial comparing warfarin with rivaroxaban, again, regarding efficacy and safety. And if we look here in systemic embolization prevention, we can see that rivaroxaban is effective as or more or even more than warfarin in prevention of stroke, and also the total mortality rate was less with rivaroxaban than warfarin. Regarding the Aristotle trial comparing apixaban with warfarin, again in stroke prevention and systemic embolization prevention, there was a significant difference between both regarding efficacy in preventing stroke, and also another significant difference regarding safety, regarding bleeding complications, and third, the total mortality was significantly less with apixaban than with warfarin. The fifth recent trial, which is the ENGAGE trial, comparing edoxaban in 2 doses, 30 milligram once daily and edoxaban 60 milligram once daily with warfarin. Again, edoxaban in the 2 doses is effective as or better if we use a 60 milligram than warfarin in preventing stroke and systemic embolization. But we can see here that edoxaban 30 milligram is as effective as warfarin and is safer than warfarin. But edoxaban, which is more effective in dose of 60 milligram than 30 milligram, is associated with increased bleeding complications. And this is a major risk. And again, the total mortality rate is significantly less with edoxaban 30 milligram compared to warfarin and edoxaban 60 milligram. So edoxaban 30 milligram is as effective as warfarin, not more than warfarin, and is safe. Edoxaban 60 milligram is more effective than warfarin, but it has a complication of bleeding more than edoxaban 30 milligram. And if we look to this figure regarding the risk of stroke versus bleeding, we can see that dabigatran in preventing stroke is as effective as warfarin, and the major bleeding is less. This means that this favors this side and this favors this side again, so it is less effective, but it's safe. And if we go to the dabigatran 150 milligram, it is very effective, but is not safe. Based on the Aristotle trial, apixaban 5 milligram twice daily is effective, and at the same time it is safe, effective in preventing stroke, and it is safe regarding bleeding complications. The second one regarding intracranial hemorrhage, all in favor of the different new oral anticoagulants. If we look to this side, all of dabigatran, rivaroxaban, apixaban, or endoxaban, or has associated with a decreased intracranial hemorrhage compared to warfarin. An important point regarding the GI bleeding, if we look to this, we can find that dabigatran 150 milligram is associated with GIT bleeding more than warfarin, even more than warfarin. And also this happens with rivaroxaban. And if we look here, the apixaban 5 milligram twice daily has no significant difference regarding GIT bleeding compared to warfarin. So dabigatran and rivaroxaban is associated with more GIT bleeding if we compare them to warfarin. Regarding the mortality, if we look to all trials, we find that the mortality rate is significantly less with the different types of the new oral anticoagulants. And again, this mortality risk in favor of the use of the new oral anticoagulants. Another important issue is that patients with renal dysfunction, we can see that apixaban, only 27% of the apixaban requires renal clearance. The rest is excreted by the liver, and so patients with impaired renal function, apixaban can be used up to a creatinine clearance of equal or more than 15 milliliter per minute. And those adjustment of apixaban, that half the dose used to use in the clinical trial, 2.5 milligram twice daily, if the creatinine clearance is between 15 and 29 milli per minute. In conclusion, in patients with non-valvular atrial fibrillation, the novel or the new oral anticoagulants, if we compare this to warfarin, are as effective or even more effective than warfarin. They cause definitely fewer intracerebral hemorrhage, and definitely they show lower mortality trend. Regarding apixaban, it is a little different from the other new oral anticoagulants. Apixaban showed significantly lower rates of quadruple outcome, stroke, systemic embolization, death, major bleeds, and intracerebral hemorrhage if we compare this drug to warfarin. Other drugs showed GIT bleeding more than warfarin. Also, apixaban showed no increased rates of GI bleeding when compared to warfarin, and it showed to have a comparable safety versus low-dose aspirin as we see in Afiro's trial. Thank you for your attention.
Thank you very much, Professor Dean, for this excellent presentation. First, highlighting the problem, which I think is very important, and then going over the potential solutions and how we should use it. And I have a couple of comments. I will have it in the introduction بتاعتك. I think it's super important. Super important. لأنه highlights the major deficiency في المانجمنت باي فيزيشنز. يعني في تو نمبرز مهمين جدا. حوالي 50% من العيانين لو ريسك بس بياخد we should not be taking. واضح ان الكونسبت of السكورينج والشاب سكور مكتوبه ومعروفه، بس بالبراكتس معظم الناس ما بتعملهاش. اللي يخش في الموضوع بيركز جزء من العاطفه. لا اصل ده الفيبريشن كذا مره. ده مش محدود. يعني انت في السكورينج سكور ما بيخش جاي له مرتين او ثلاثه او اربعه او 142,000 مره. It's not included. الحاجه الثانيه انه 42% we should be taking are not taking.
تمام بالظبط. وفي افريكا بيوصل 60% of the patients who are at high risk.
اذا المشكله الاساسيه ان المفروض ما ياخدش ياخد طبعا بيكون كنترول، واللي المفروض ياخد ما بياخدش. I think it's very important ان احنا to relook نلتزم ده الساينس مين اللي بيجيله من الانفيوجن. بشوف ناس تقول اصل الليفت اتريم كبير. It's 41. We had one incidence of atrial fibrillation, and 2 incidents of atrial fibrillation. بس اصل left atrium 4.1 كان كبير. It's not included. لازم نلتزم لانه التيبلز المكتوبه دي ملخص ابحاث كثيره جدا وتحليل عميق ودقيق جدا لعشرات الالاف بل مئات الالاف من العيانين. احنا لازم نهتم ان احنا نلتزم بيها وما نقولش لا اصل العيان بتاعي مختلف. هو مش مختلف عن ال 200,000 ولا 300,000 التانيين. اكيد كان فيهم ناس زي العيان بتاعنا. think this is very, very important. حاجة تانية إنه these group of drugs are very beneficial, very effective, with breakthrough. When we compare them, and I really like كام سلايد هحطهم اللي هم warfarin method, الأدوية method. It's possible يا ريت تحط لنا سلايدز، هم 2 سلايدز والثلاثة ورا بعض اللي حضرتك صورتهم. أيوه اللي هو البنفيت والبليدنج. ده الميجر بليد. هو السلايدز دي مهمة جدا، هي تبدو انها بتلخبط بس اكشلي اسهل سلايدز الواحد يقراها. لو بصينا على اليمين الخط الطويل، على الشمال يبقى الادويه الجديده احسن واحسن بقد ايه؟ هم ادويه كتير. كل ما تبعد عن الخط اللي بالطول يبقى احسن اكتر. وهتلاقي انه البيكسبان بعد عن الخط اللي هي دايره الخط اللي هو مع بهايلايتد بالاحمر ده، انه بيبعد. الثلاثه التانيين اللي فوقيه على الخط او قريبين جدا منه، اللي تحت اقرب منه هو بعيد خالص عن الخط. مش ميز انه حتى لما نقارن بين الكومباتيتورز اللي هم زيه بيشتغلوا بنفس الميكانيزم، الانسولين بليدنج اقل بكثير، وبالتالي هو احسن بكثير عن الاورال انتي بايوتيك العادي. انت بتقلل البليدنج بالنسبه للسايد افكتس اللي انت قلقان منها. انت بتقول الله بس انا ما بحللش فانا خايف يكون هيزود البليدنج. نو، ده بيقلل وبيقلل اكتر من الادويه بتاعته. بيقلل عن الورفرين وبيقلل عن بقيه الادويه. فدي حاجه مطمئنه جدا 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 regarding السيفتي بالنسبه لنا. طبعا البنفيت is obviously there وكله على شمال الخط اللي هو البنازل. انت بتاخد البنفيت وفي نفس الوقت سكيور ومطمئن ان مش هيحصل فيه مش This slide, I think, is very, very reassuring regarding the what and potential side effects of the bleed. I think number one, we have to rethink the way we practice, and remember this slide. I think it will be a lot of specific.
يعني بس انا برضه احب اضيف كومنت على اللي قاله ايمن تكمله للانترودكشن، ان بالرغم في 50% من البيشنتس ما بياخدوش، ال 50% التانيين اللي بياخدوا ما هوش ويل كنترولد. ده في جزء كبير منهم اوت اوف ذا ثيرابيوتيك رينج، ايذر اندر ودول ات ريسك اوف ستروك، اور اوفر ودول ات ريسك اوف بليدنج. حتى ال 50% التانيين ما هماش بروبرلي كنترولد. عشان كده I think ان الوارفرين is about يعني once ان الدراجز دي تبقى available يمكن البرايس بتاعها يبقى ريزنبل، الوارفرين will be dead like الادويه القديمه اللي احنا كنا بنستعملها في الانتي بليتلت.
احيانا او كثير موضوعات واهميه الريليشن هي انه الديزيز ده جروز بالجيش، وبالتالي المجتمع بتاعنا المصري اصبح مور ايج، وبالتالي مش اصبح مور. طبعا احنا عاصرنا التجاوز الفتره اللي بنلاقي ان في تشينج كبير جدا في دكاتره الريليشن دي بين ومعها disease was the most prevalent cause of condition, but now we are compared to the more advanced countries with incidence of ischemic disease and hypertension, etc. طبعا الموضوع اساسا في حاجات كتير، لانه التغيرات اللي حصلت سواء كانت في الثيرابيوتكس بتاعته ولا مثلا حاجه زي السيرجري بينما الابلكيشن family condition or other كونديشن. يعني انت فاكر ان الموضوع مهم جدا وانت
شكرا.
We'll take one last question. We have to finish عشان the علي صوتك بس عشان
regarding the parasitic calculation, what is the
هو اذا كان بارازيت
اخر كلمه في السؤال.
regarding calculation, regarding the parasitic calculation, and what's the one parasitic or multiple parasitic? What's the lot of
هو ده مش كرونيك اتريال فابريشن بس، هو نون فالفولار اتريال فابريشن وذر كرونيك اور باروكسيزمال اتريال فابريشن. احنا بنعمل السكورنج سيستم، السكورنج سيستم ده بيخليك يتحط البيشنتس في انهي ريسك كاتيجوري، ده لو ريسك، انترميديت ريسك اور هاي ريسك، وذر هو هي هاز ا كرونيك اتريال فابريشن اور باروكسيزمال اور انترميديت اتريال فابريشن. لو هو في الهاي ريسك سكور حتى لو باروكسيزمال اتريال فابريشن this an indication of oral anticoagulants.
والحقيقه الدكتور عطيه الله يرحمه كان بنحاول نتكلم على الفرق بين الكونديشن والكونديشن. كان ليه راي يقولوا ان الكونديشن is more serious than the كونديشن لانه العيان ليه من فتره هو فيها انسان سيري الى فتره كده دايركت والنص يحصل اول ما
كونتراكت
Thank you very much. And I think we'll move on to the next session, endovascular perspective of peripheral vascular disease.
احنا ندخل على طول على السيشن. استاذ دكتور محمد عوض طاهر. اتفضل بيه. الحقيقه عشان احنا بس حاسين انكم يعني هتجوعوا او جعانين او جوعتوا، فاحنا هناكل بدري شويه فنخلص السيشن دي عشان ندخل على الغداء على طول.
ايه قريب عشان فاكر في مشكله حصلت.
Now we're coming to the last session. This really very crucial meeting. And last session, of course, I hope you will be still awake and concentrated after that we have lunch. We have 3 speakers in this session. The first one, Dr. Wasila Taha, is going to speak about ultrasound guided recanalization of long superficial femoral artery.
Thank you, Mr. Chairman, and thank you, Dr. Muhammad Awar Al-Farouk and the organizing committee for their nice invitation and including my presentation among such a distinguished program. My presentation entitled Ultrasound Guided Revascularization of a Long Superficial Femoral Artery Occlusion. And I will raise a question, why? Why do we need reflex-guided endovascular interventions? In fact, it's a very appealing modality. It's en vogue, c'est à la mode, and it's an emerged safer alternative. Safer alternative for both sides. For the patient side, we know the vast majority of our patients are fragile diabetic patients with impaired kidney function tests in the most of the time, as well as for the operator side. There is no radiation exposure. And please don't take no radiation exposure as a light phrase. It's very important. I'm sorry about this scary slide, but if you are a busy interventional operators and you have to do long procedures like EVAR, complex procedure for long CTOs, angioplasty and stenting, you are at risk for these hazards and you are at risk to affect your eyes, gonads, hands, and forearm. And here are the thresholds of the RAMS per year. So the advantage of the non-invasive ultrasound modality, the duplex guided vascular interventions, it offers you no radiation, no nephrotoxic material, and important tips. There is visualization of the entire arterial wall. It's not luminology, it's not silhouette angiography, but you, in real time, you see the arterial walls. So the sensitivity of this modality in detection of the very low flow, it helps you to visualize the stump appropriately. It helps you to take the precise measurements of the transverse diameters, of the length of the lesions. So based on these measurements, the accurate measurements, you can choose your tools either for the balloons and stents with an accuracy, high accuracy. And important information, the hemodynamic parameter. The duplex, it provides anatomical, morphological information as well as the hemodynamic parameter based on which you can properly select which lesion could be corrected and what type of, how much the quantity of perfusion of the foot will need. It's not a surprise that we have a large experience in duplex or vascular ultrasound for nearly 20 years now. Duplex guided interventions need some experience before to start or to emerge to duplex intervention. You have to get some experience for the conventional arterial mapping. Of course, we have a large experience in this domain. And I would like to share with you our case. It's about a gentleman Sudanese patient of 69 years old, coming up in our department complaining of the right foot gangrenous peak toe with patch of necrosis at the dorsum of the foot. He is diabetic and hypertensive. By examination, he had palpable common femoral artery, absent popliteal and tibial pulses. According to his workup, his labs, the serum creat was 2 before the CT angiography. He underwent CT angiography, but outside our department, likely in Sudan, and it reveals long SFA occlusion with tibial artery disease. And unfortunately, his serum creat raised to 2.7 after undergoing the CT angiography. Coming up in our department, seeking for correction of his status, and we performed a high quality of duplex in our department, and it relieved this map. We have a long SFA occlusion, about 27 centimeters long. We have a transverse diameter of 5.3 millimeter. We have a good information about the inflow status, the orthoiliac segment patent and spare, the common femur, the profunda, and a good information about the outflow. We have a total occlusion of posterior tibial artery. We have a disease along the multiple stenotic tendon lesions of the anterior tibial artery, and importantly, we have a good parameter, meaningful and objective parameter based on which we can categorize the degree of ischemia. And here, for this category, we have a critical dealing with the critical limb ischemia. And moreover, we have a very important tip which could not be provided by the CT angio. We have the structure or the characteristics of the lesion. It was a homogeneous structure and with lots of calcifications. So we thought it's a neglected thrombus on top of atherosclerosis. And importantly, we have the degree of ischemia, of course, calculated by our invention, the ankle peak styloplast. This is how it looks, our vascular lab, our setup. We have what we call the hybrid technique. So we combine both technology, both modalities, the vascular ultrasound with the fluoroscopy. And we do just a skin mapping before the intervention to leveling the site of the lesion, the proximal side and the distal side. We have the appropriate linear probe of the vascular ultrasound. It's a 7.5 megahertz inserted in a sterile cover. And then we sterile the whole limb. It's not only the groin sterile, but we do sterile the whole limb. And every step is monitored by duplex. Here we have the puncture, the common femoral artery, the contralateral left common femoral artery, and we cross over from the left common femoral artery to reach the contralateral side. And here, the first run, I beg your pardon. عايزة بس الصورة اللي فيها. This is the first run. We can see total occlusion of the SFA and sparing a very short stump with the dominant profunda. And here, what it looks, the duplex guided procedure. We have the wire and the patent profunda femoral artery, stole the wire, and we try again, and we succeed to cannulate the proximal segment of the superficial femoral artery. Here we are inside, and advancing the wire from the proximal to the middle. And here we can encounter some resistance by certain maneuver and negotiation. We succeed also to continue advancing our wire. Here we are. And then again, some resistance. Every step is monitored with good visualization of the wire, with good visualization of the entire wall. We can see the anterior wall, the posterior wall. And here we end up to succeed to cross all the long lesion and to park our wire in a patent spared distal SFA part. We have the privilege to magnify the image to see more in details what happened. And we start the ballooning, and please note with me how it conformed very well, the diameter of the balloon, how it conformed very well with the native transverse diameter of the SFA. And then we deflate and we retrieve the balloon by the color flow. Now we can assess and evaluate how we have now after ballooning, but we can see some filling defects around the balloon and the wire. Now we can magnify much more to see in details if there is really residual hemodynamic significant stenotic lesions or not. And here we are. What is very alarming here, it's a significant stenotic lesion. And on static image here, we have multiple tendon stenotic lesions and even with short dissection. And these pictures were what we have along the recanalized long SFA. So we decide to stent the long SFA along, and here the deployment of the stent. Every step is monitored and is well visualized, guided by the duplex. Here how it looks at the stent deployment. And again, from the proximal, it's a long stent, and we can, every centimeter of the stent, we can really well visualize it. And here how we assess our stent. Let me pardon again about the loop here. I'm sorry for this. Here is not presentation. Yes, this is an angiogram showing the patent stent and the successful result. And this must be also a cine loop showing by the color flow how it looks like. So we have a dual imaging to assess our technical success. Moreover, as I mentioned before, the beauty of the duplex that it provides a hemodynamic parameter. So we have the three cardinal parameters of the duplex. Here we have on the gray scale the distal end of the stent and how it conformed very well with the native transverse diameter, beautifully deployed. And also the patency by the color flow is the full saturation of the cavallar flow along the artery, and also the hemodynamic success. And we have the peak systolic velocity here reaching approximately 100 centimeters per second. And back to the map before intervention. So we fixed this long SFA occlusion, and our plan was to go next to recanalize or to fix the anterior tibial artery, which is very relevant to the endothelium of the complaint of the patient. Reminded it has a patchy skin of necrosis on the dorsal of the foot. And here the wiring again of the anterior tibial artery was performed under duplex guidance. And here the completion duplex imaging. We have a good saturation of the anterior tibial artery. We have normalizations of the artery. We have an 85.5 centimeters per second, while before intervention it was 21 centimeters per second. look to the review of the literature, we have to remind such name, Enrico Asher. In fact, we consider Dr. Enrico Asher as the godfather of the duplex-guided interventions. And if you put on Google Scholar, just duplex-guided interventions, here we have a long list of the vast publications conducted by Dr. Enrico Asher. It has a wonderful setup in Brooklyn, in New York. He has a wonderful cooperative team. He has Nathalie Marx, is a very eminent vascular surgeon with strong capabilities of duplex in the duplex domain, and Anil Hingorani, and I do have really large series. This is the largest case series reported using the duplex-guided interventions, the femoropopliteal artery. They do have 253 angioplasties between all the categories of the task, with an overall technical success 93% in the stenotic lesions and 73% when we are talking about CTOs, long lesions, femoral or popliteal vessels. And also there are some cases reported in literature by Dr. Kawarada, performing also very similar to our case, chronic SFA total occlusion and under ultrasound guidance. To conclude, Mr. Chairman, duplex-guided endovascular procedure is feasible, and it's an appealing tool in order to avert the harmful effects either for the patient or for the operator. And additional advantages include accurate selection of the proper size and measurements of balloons and stents, confirmation of the adequacy or the success of your techniques by morphological as well as by hemodynamic parameter. Currently, many concerns are put to extend the boundaries of the vascular ultrasound, which would really expand and change the horizons of our clinical practice. And thank you.
Thank you very much, Sheila, for the message that you gave, and we have 3-4 minutes time for questions. And want to ask something?
I'd like to ask, thank you very much for the very elegant presentation. It's very important, very nice news. One question: in this case, you have a creative just to concern mostly. How many injections do you have? You still have some antibiotics?
Yes, just 2 injections.
It's duplex assisted. It's complex.
Yes, no, it's duplex guided in a way that we are wiring the SFA occlusions by the duplex. Let me answer your questions in the priority. You asked about the runs. We have just 2 runs. The first one, as we see, to confirm what we had by duplex imaging. We had a total occlusion of the SFA, just a sparing short stump. This is the first run, and the completion one. But all the stents was run guided by the duplex. We cannot call it's a duplex, mainly duplex. As I mentioned in my slides, it's a hybrid technique. You have your vascular ultrasound machine inside your angio suite. So you combine both modalities to get the most benefit for your patient.
You ended up with 30 mL of...
very few. Very few.
Very nice presentation. Could you highlight the disadvantages of this technique?
I beg your pardon, I didn't get the question.
The problems, the potential problems of this technique. I mean, you talked very well, you presented very well the advantages. Can you just highlight the problems with this technique?
I don't think there is problems for this technique. The only problem is the lack of experience. If you don't have enough experience, if you are not monitoring your modality, and if you don't know the capabilities what given by your machine, I think you will be stuck. You cannot get such technical success.
Okay, I think we should move to the next speaker. We need to leave in 30 minutes. So next speaker is our friend, Professor Ashraf Badawi. The story is new European Society of Cardiology guidelines for the management of pulmonary hypertension.
in a very short slide, كلنا هنبقى precise ومش هنبقى في discussion
as concise as possible. Thank you, Dr. Muhammad. Thank you for the presentation, and thanks for the organizing committee. I will give a short resume for the new ESC guidelines of pulmonary embolism. First, I will talk about the diagnostic algorithm, the role of D-dimer, the areas of uncertainty regarding the CT angiography, MRA dilemma, and the pregnancy issue. Then we will move fast to the management. First, the diagnostic algorithm, suspected acute pulmonary embolism if the patient is shocked or hypotension or hypotensive. This is a high risk, it's not a high risk. CT angiography in patients with shock or hypotension, if it is positive, proceed directly to the treatment. Negative, search for other cause for the hemodynamic instability. If CT is not available, proceed to echo. If there is an RV overload, yes, go to CT angiography if available. If not, go to direct to the treatment. If there is no RV overload, so proceed searching for other cause. In the suspected pulmonary embolism without shock or hypertension, assess for the clinical probability of pulmonary embolism. If the patient is high clinical probability for pulmonary embolism, CT angiography and proceed. If low or intermediate risk, proceed to D-dimer. If it is positive, CT angiography, pulmonary embolism either confirmed or no pulmonary embolism. If it is negative, so no treatment. The D-dimer issue, what's new in this guideline that the age-adjusted cutoff increased the diagnostic yield of D-dimer. So right now we have in the patient less than or equal 50 years old, the cutoff is 500 nanogram per ml. Above 50 years old patients, we have to multiply the age by 100. And this was the adjust study that we used in these guidelines. And the guidelines stated that plasma D-dimer measurement is recommended in outpatient emergency departments patients with low or intermediate clinical probability or pulmonary embolism unlikely to reduce the need for unnecessary imaging and irradiation, preferably using the high sensitivity assay. And this is a class 1 indication level of evidence A. In low clinical probability or pulmonary embolism unlikely patients, normal D-dimer levels using either the high or moderately sensitive assay excludes pulmonary embolism. D-dimer is not recommended in patients with high clinical probability of pulmonary embolism. Regarding the CT issue, CT angiography showing a segmental or more proximal thrombus confirms pulmonary embolism. Further testing to confirm pulmonary embolism may be considered in the cases of isolated subsegmental clots, taking into account single versus multiple subsegmental clots, the clinical probability, and the bleeding risk of the patient. Incidental pulmonary embolism is present in about 2.6% of regular CT chest with contrast done daily. And regarding the management, incidental pulmonary embolism in patients with cancer should be managed in the same manner as symptomatic pulmonary embolism. No cancer, no recommendation in these guidelines. The MRA is not recommended for the use to rule out pulmonary embolism. In pregnancy, perfusion scintigraphy may be considered to rule out suspected pulmonary embolism in pregnant women with normal chest X-ray, 2B level of evidence C, and CT angiography should be considered if the chest X-ray is abnormal or if the lung scintigraphy is not readily available, but take care that this increases the maternal breast radiation exposure 10 to 20 times. D-dimer measurements may be performed in order to avoid unnecessary irradiation, as a negative result has a similar clinical significance in the non-pregnant patients. Going to the treatment modalities of pulmonary embolism, this was the guidelines at 2008. Initial treatment, thrombolysis, low molecular weight heparin, fondaparinux, and unfractionated heparin. Long-term treatment, keeping an INR with the vitamin K antagonist, keeping an INR 2 to 3. Then the extended treatment, maybe we can keep the INR in a range of 1.5 to 1.9 according to the baseline risk. The change that occurred in these guidelines in the anticoagulant treatment, the new oral anticoagulants, namely the rivaroxaban, epixaban, dabigatran, and the edoxaban, all of them have class 1 indication with level of evidence B. But there are some remaining questions. Could the new oral anticoagulants facilitate home treatment? Are there sufficient data with the new oral anticoagulants for intermediate high-risk pulmonary embolism as an initial treatment? Are there sufficient data with these new oral anticoagulants for patients with cancer? These are still unanswered questions. So for the acute phase treatment, for patients with pulmonary embolism and the cancer, a weight-adjusted subcutaneous low molecular weight heparin should be considered for the first 3 to 6 months. For patients with pulmonary embolism and the cancer, extended anticoagulation beyond this period should be considered for an indefinite period or until the cancer is cured. For patients with pulmonary embolism secondary to or transient reversible risk factor, oral anticoagulation is recommended for 3 months. Anticoagulation treatment of indefinite duration is recommended for patients with a second episode of unprovoked pulmonary embolism. Rivaroxaban, again, the dabigatran and the apixaban should be considered as an alternative to vitamin K antagonists, except for patients with severe renal impairment, if the extended anticoagulation treatment is necessary. Finally, the apixaban, dabigatran, rivaroxaban are more effective than placebo in preventing vena thromboembolism recurrence without increasing the risk of major bleeding. Dabigatran is non-inferior to warfarin for its primary efficacy outcome with a potentially reduced risk of bleeding. This is with the dose of 110. Going to the role of thrombolysis in intermediate high-risk patients, routine use of primary systemic thrombolysis is not recommended in patients without shock or hypotension. In patients with hemodynamic decompensation, thrombolytic therapy should be considered. And finally, the role of interventions in acute pulmonary embolism. Surgical pulmonary embolectomy is recommended for patients in whom thrombolysis is contraindicated or failed, +1 indication. And percutaneous catheter-directed treatment should be considered as an alternative to surgery for patients in whom full-dose systemic thrombolysis is contraindicated or failed. And this is the final slide. Treatment of pulmonary embolism. High-risk patients, thrombolysis as an initial treatment, then continue with the vitamin K antagonists or the new oral anticoagulants for an extended treatment. Intermediate and low-risk patients, low molecular weight heparin or vitamin K antagonist, or low molecular weight heparin, then new oral anticoagulants or the new oral anticoagulants from the start. Thank you.
And now we shift to the last speaker. So I'm going to present endovascular management of some area veins.
Bismillahirrahmanirrahim. I would like to thank Professor Rida Al-Isri and Professor Omar Farouk for giving me the honor to be here in this marvelous scientific event. في الحقيقة أنا vascular surgeon. That's why I choose the subject to discuss today, everyday practice. ما يبقاش specific vascular أوي. This is my disclosure, my disclaimer. This is why I put my first slide for the very familiar picture for all cardiologists. This is the picture of pacemaker and discussing how it may affect the central veins. And as we see, this is a subclavian vein stenosis, and we try to dilate it. And you see how the balloon suffers much to dilate this vein with intact pacemaker. And this is the final result. It is important to remember that central veins differ a lot from arteries. And the elastic coil of central vein had been discussed by Davidson in the journal of Kidney by the year 1991. Utilized in the vascular ultrasound to evaluate the mechanism of angioplasty induced of elastic recoil post-angioplasty, and he found that central vein elastic recoil was reported in 64% of these patients in the central vein, while it is recorded in the peripheral vein on only 37%. That's why angioplasty of the vein is differ a lot from that of the artery. Let us define the problem. Subclavian vein stenosis is most commonly the result of prior catheterization. Stenosis or occlusion of this segment can be devastating for patients. There is no real durable solution. This fact, no real durable solution for this problem. When to intervene, this is very important. Can we intervene on clinical findings or ultrasound finding or radiological finding or all? We have to discuss overall points of treatment. We have the angioplasty alone, angioplasty plus stenting, either covered or uncovered. Surgical intervention is very important, and that's unique for surgeons, or doing nothing. Angioplasty. Let us remember this number. Subclavian vein angioplasty is widely accepted as the primary treatment adapted. And we have to know that all literature or retrospective studies, no randomized clinical trial had been done for this problem. All the number of these studies are small number, are very quite small numbers, and there are many reasons for this stenosis. And the overall patency rate for these results ranges from 29% to 35% at 1 year, and primary patency rate ranges for about 2.5 months. This is very quite easy procedure. This is the stenosis segment. We have to see this is very tight stenosis, which managed very successfully with angioplasty. This is another case of athlete, 25 years muscular patient, presented with acute subclavian vein thrombosis, and we successfully dilate and make thrombolysis of this patient. And we treat this guy with splenectomy and first degree resection, because we all know that this is a picture of thoracic outlet syndrome. If we leave this guy, he will re-thrombose and re-thrombose again. This is another case of successful subclavian angioplasty. Now, why I like angioplasty? It is an outpatient procedure, relatively cheap, can be done multiple times. But I don't like it is not a durable solution. There is evidence that the PTA may worsen rate of stenosis. We conducted our series on 96 patients admitted to vascular surgery department with clinical manifestation of venous hypertension of the upper limb from May 1st, 2009 to April 15th, 2013. We presented clinically with chronic swelling of the axis of the arm, subcutaneous collaterals around the shoulder and the thoracic aperture, ipsilateral swelling of the face, neck, and breast, pain, and paresthesia. I will skip this picture. Of course, we all know that technique. We have to discuss some facts. As you see, this is a classical picture of, this is classical picture of stenosis subclavian vein, which is dilated, but we have to know that the technical success ranges from 77% to 90%, 20%, patency rate of 12% to 50% in 1 year. Cumulative patency rate may raise up to 70% in 1 year. Reported occurrence may report to 100%. That's why we have to modify the technique or and we have to make it better. How this improve may need stent or do something else. This is how we do the angioplasty, and we used very successfully and peaceful management, and we have very successful results. But 4 months later, recurrence of the problem occurs again, and we successfully make it better within a few minutes in the cath lab. This is our results. We have excellent results in 20% of our patients, good results in 60% of our patients, fair results in 13% of our patients, and poor results only in 7% of our patients. But we have recurrence in 65% in our patient after 6 months. This is the important question, stent or no stent. Going through the literature, we found that we have to avoid deliberate overstenting and stretching of the jugular vein, keep stent length as short as possible, bridge the entire lesion with slight overlap at proximal and distal end, choose stent size with largest possible diameter for effective vein, depending on the lesion inside, adapt size to the diameter of adjacent non-stenotic vessel segment. All patients who presented with recurrent cephalic arch stenosis more than 50% within 3 months of successful balloon angioplasty were randomized to have angioplasty and stenting with a bare nitinol stent. This is how successfully we can open the totally occluded subclavian vein and dilate it. Then with our stent, again, another case, and in this case, you see, this vein is compressed between the clavicle and the first rib, and you see how there's a very big waist in the balloon, and you can predict that this raised stenosis will occur very shortly after angioplasty. This is the successful angioplasty and the balloon. Again, this is how to meet the pre and post angioplasty results. And we use the graft stent successfully. This is the very nice picture showing how the covered graft patent and deployed successfully in the vein. But we have to remember this. To the right, this is the successful case of angioplasty. And the bigger one, this is the recoil just 20 minutes after angioplasty. Just 20 minutes. This is what do you think? Is it a beautiful case? Yes. As you see, there's still more than 30% of residual stenosis, and I think this is considered as a technical failure. But disappearance of the collateral veins make it hemodynamically successful, and absence of the arm swelling make it clinically successful. That's why, as a clinician, we emphasize that it is very important to mix all these technique or results together. The clinical success and the hemodynamic effect and the clinical effect, not only the technical success only. That's why I think this, although this is a technical failure, it is successful. This is the nightmare, how the stent compressed between the clavicle and the first rib. And again, this is in the hyperabduction position, how the stent compressed in the thoracic abdomen syndrome. and this is necessary what we discussed. Surgical intervention. Surgical intervention must be in the mind when we're dealing with the central vein stenosis or occlusion, either by doing extra-abdominal bypass using axillary to jugular or axillary to femoral bypass, or even subclavian atrial bypass using patch graft. But we have to remember that literature, there is a very minimum or limited number of surgical cases, and medium or long term the results are late. That's why I like surgery. Why? And I don't like it. I don't like it because AV access often have concurrent lesions, and patients have multiple comorbidity, and there's always limited resources. We have to keep these resources for creation for new access, and there's, however, still a role of surgery. This is literature which compared published by Patia, which came to the result that similar symptoms of free survival at 6 to 12 months of both surgery and angioplasty, while Labette formulated the PTA of symptomatic or asymptomatic subclavian vein stenosis greater than 50% is in the setting of intermittent access. Memphis procedure was associated with more rapid stenosis progression and acceleration of the lesion. In summary, subclavian vein PTA is better as a primary treatment compared to surgery. PTA should be performed for the correct reasons: access dysfunction, clinical symptoms, and a better solution is needed. And I have a final word: surgical resources are better applied elsewhere. Please don't place subclavian catheters so none of us have to worry about this problem. Thank you.
كان كل المواضيع اللي اتقالت دي مواضيع تنفي ديسكشن، بس عشان في خاص هنا القاعه دي احنا فيها. اليوم كان يوم غني جدا، وبكره في سيشن قبل الصلاه يا جماعه من 10 ل 11 بتاعت مانسيري ورك شوب فيري امبورتنت. اي هوب ان احنا نكون طبعا، وبعد كده بقى في الغداء والعشاء.
الغداء ان شاء الله في المطعم الرئيسي للفندق امام القاعه مباشره. المطعم الرئيسي للفندق امام القاعه مباشره.